prominent speakers for today. Dr. Ajit Nair, sir, which is the faculty at YMT Dental College. Dr. Mayur Kaushik, sir, Head of Department, Subharti Dental College and Hospital, Meerut. Dr. Ajit Nair, sir, will be enlightening us with the topic on perioceutics more than prescription, helping us dwell more deeper and get a better understanding of the same. Dr. Mayur Kaushik, sir, will be sharing his vast knowledge with us on the topic periodontal surgical considerations in implantology. Also, today being Janmashtami, I wish you all a very happy Janmashtami and pray that the Lord shower his choicest blessings upon us and be with us throughout. I now call upon Dr. D.G. Pol, sir, who is the pillar of the ISP MSG group, to carry on the further proceedings.
Thank you, Lynette. So, at the outset, may I give the best wishes for the Amrut Mahotsavi Independence Year to all. And today is Krishna Janmashtami today. So, President Dr. Manish Khatri, Secretary Dr. H.S. Grover, Organizing Chairperson as today's convention, Dr. Varsha Rathod, Organizing Secretary Dr. Rajesh Gaikwad, all the members of the ISP, MHG, aides, faculty, PGs, delegate, keynote speaker Dr. Mayur Kaushik and Dr. Ajit Nair, welcome you all in this convention. Friends, with due respect to the newly amended ISP Constitution, ISP Master Group, who was there the last 15 years, now it is working as a ISP Mumbai, but it is abbreviated, it is continuing as a ISP imaging with same aims and objective. So this is in continuation of the ISP imaging convention. Due to heavy rain in Mumbai, we could not organize physically. And today also, and since last 4 days, a few days for heavy rains, you must be observing, and hence we are having this virtual convention. I wish to welcome our President Dr. Manish Khatri, very active and young and enthusiastic. Secretary Dr. H.S. Grover, very prompt in action, short spoken, and really it's straightforward and blunt in taking decision. And with this, that actually you always write in each and every circular and the letter, we are politely informing you. That is what his style of working. I welcome you, Dr. Manish Khatri and Dr. H.S. Grover, Secretary Head Office in this convention. A beautiful, ever smiling lady, organizing chairperson Dr. Varsha Rathod, very dynamic, and it is always at our service. Welcome you, madam. Dr. Rajesh Gaikwad, who is a real worker from the grassroots level, always accepting the challenge and try to implement in all the aspects. So in dentistry, in cultural field, in the perio, social, cultural, and always in the singing, and always about everybody's birthday, he always give the colas during the birthday of each and every member. So having this particular, that is highly prosper man, Dr. Rajesh, I welcome you. And our main speaker, that is Mayur Kaushik and Dr. Ajit Nayak. Dr. Mayur Kaushik, since I have seen him as a student, and really he's become I'm very happy to say he's become a celebrity speaker nowadays. And everywhere once his lecture is there, the people try to join this particular lecture. Few members, few periodontists and general practitioners also join by quoting his name. I wish to join this Mayur Kaushik lectures. At the outside, yesterday, he birthday was there on 18th August. And may I wish Dr. Mayur wishing a very, very happy birthday.
Thanks a lot,
Doc-
sir. Thank you.
Dr. Ajit Nayak, it's a very intelligent and talented person in Peru. And may I say about my with interaction with the several occasions with Ajit Nayak since during his examination till date, it seems to be Ajit Nair seems to be एक उभरता हुआ सितारा है प्यारी. So I have chosen this to speakers this particular today's convention. I welcome all the members, organizing committee, PGs, head, delegates, and friends, and the delegates from the abroad. So ISP senior members in ISP Dr. Chitnis, which I have seen. Dr. Dani is also working at my talk, joined, and he committed when he is going to be joined. So Dr. Dani and all the president, secretary, and all other members of the convention committee. So ISP is eagerly waiting you along with the ISP president, secretary before the next week for the venue inspection. So you are welcome, sir, at that time. So friends, let us share and remain united. So start working from the grassroots level and take and accept the challenges. Like this, I wish to end my this particular small this thing speech with this share. तुम इस चिरागों की तरह इस बाग में चमकते रहो. तुम इस चिराग की तरह इस बाग में चमकते रहो और इस मन की अंधेरों को उजाले में बदलते रहो. Thank you very much. And may I hand over this particular thing to Planet and Vaibhavi for further proceedings.
Lovely poem, sir.
I think this our president sir and secretary sir, I request them that they should give a brief message and guide all youngsters, all young budding periodontists, and all the ISP live members. Our secretary sir.
First, you call Baba Manish, Dr. Manish. Manish, our president first, and thereafter about the secretary.
Okay. President sir.
Thank you so much, sir. Say at the onset, on behalf of the Indian Society of Periodontology Head Office, and in my capacity as the acting president of the society, I wish you all a very happy Janmashtami and wish that may Lord Krishna bless us all. And it gives me great pleasure to welcome you all most cordially to yet another scientific extravaganza organized by the Indian Society of Periodontology Mumbai Study Group, the Virtual Scientific Convention 2022, and this is the 8th one they have been organizing. And we all know that the Indian Society of Periodontology is an association of the periodontists of India, and its primary aim is to promote and enhance the knowledge and the science of periodontology in India, and plays a major role in organizing frequent scientific meetings, seminars, and conferences at periodic intervals in order to provide a great opportunity to the students and clinicians to learn more about the extremely important branch of dentistry, the backbone of dentistry, which we all know as periodontics. The Indian Society of Periodontology Mumbai Study Group has been organizing this event for the 8th year now. And this event of theirs has always been acknowledged by the participants as far as the scientific content of the convention is concerned. Congratulations and 3 cheers to the Indian Society of Periodontology Mumbai Study Group, especially Dr. D.G. Paul, Dr. Varsha Rathore, and Dr. Rajesh Gaikwad for organizing this event here today. I assure all the participants that this would be a great learning experience for you all with the knowledge-packed sessions of Dr. Ajit Nair and Dr. Mayur Kaushik. I extend my warm greetings and felicitations to the organizers and the participants and wish this event a stellar success. Thank you all. Happy learning and God bless.
Thank you, sir. Secretary, sir.
Yeah, thank you, Dr. Rajesh. Good evening and Janmashtami greetings from New Delhi. Always a pleasure to join any activity conducted by ISP Maharashtra Study Group. Actually, the Oral Hygiene Day itself has been a brainchild of Dr. D.G. Paul, and Sir has started this tradition, almost 22 years ago. And this virtual convention usually is a part of, or you can say, the extension of the Oral Hygiene Day celebrations, which this year also we celebrated with great enthusiasm all over India. And the number of reports which are pouring into the HO shows the great enthusiasm every college participated with. Regarding this convention, I must say that Dr. Rajesh Gaikwad, Dr. Varsha, and Dr. Paul has managed to rope in two of the finest exponents in present day perio scenario, Dr. Mayur Kaushik and Dr. Ajit Nair. Both of them are well known and very enthusiastic speakers. Both of them have chosen to come up with nice topics. Our branch is blessed with certain unique we can say areas such as periodontal medicine and perioceutics, of course. So today's talk on perioceutics and of course the surgical considerations which are there in implant dentistry by Dr. Mayur. I'm sure the audience, including the senior members of ISP and the other life member delegates, would actually enjoy the deliberations. So in the end, I can say that if the head office is the brain or the heart of the ISP, all the study groups are actually the spine of the ISP and they keep us moving. And MSG, ISP MSG is one of the most active study groups under the leadership of Dr. Paul and Dr. Gaikwad. With these words, once again, greeting from the head office and happy learning to all the delegates. Jai Hind.
Thank you, sir. Now,
Thank you, sir.
Lilith. Yeah.
Now we request ma'am to continue the further proceedings by introducing and moderating the further session.
Good evening, one and all the pioneers of Indian Society of Periodontology, my teacher and my fellow mates. My teacher, Dr. D.G. Paul, Dr. Chitnis is also seen here. Good evening, sir. We are very happy to see you on screen today. So I warmly welcome you all, and it is my privilege and I feel proud to invite you all and welcome you all today's evening on the eve of Janmashtami, and I give best wishes to all of you. So I have been given the onus of being the organizing chairperson for today's convention, and I have to introduce the very well-known speakers. When I went through the CVs of these well-known speakers, the first one comes Dr. Ajit Nair, and it is very shocking and very happy this thing to know that Ajit had achieved gold medal during his BDS, final year BDS in 2007. And after 7 long years of clinical practice as a BDS, he opted for our branch of periodontology to pursue his master's. And we all should feel proud about it after 7 years. And he again achieved gold medal in his MDS degree also. And he is very actively practicing nowadays exclusively perio, which are very few of us in the country. And in 2007 and 8, he had a massive study done on clinical attachment in oral and maxillofacial surgery at National University of Singapore. So currently he is attached to Yela Medical Trust College and Hospital at Kharghar. And he's also a very well-known clinician and an academician to all the youngsters. So I welcome you, Dr. Ajit Nair, and we are very keen to understand your keynote lecture for today. That is perioceutics, yeah, more than prescription. So over to Dr. Ajit Nair.
Thank you so much, ma'am, for your very kind words. I would also like to, at the onset, begin with thanking ISP for this platform. Acting President Sir Dr. Manish Khatri Sir, Secretary Sir Dr. H.S. Grover Sir, and definitely ISP Mumbai Study Group, Dr. Paul Sir, Gaikwad Sir, Varsha Rathod ma'am, and senior academician Chitnis Sir. Thank you so much for being a part of this convention today. And I would say it's such a privilege not only to be speaking on this platform, but also speaking alongside Dr. Mayur Kaushik. I have mentioned this to him earlier as well, that when I was a PG student, I have attended his lectures. So to be on this side alongside him is a huge privilege. And I should once again thank ISP, MSG for giving me this opportunity and this platform to be able to speak to the young guns of Perio and the future of our branch. So I think without much ado, I will start off with the topic that I have been allocated today. Let me just share the screen.
So I request all the participants to kindly mute yourself so that we can clearly hear our speakers today. And also questions, if any, please write in the chat box so we can take it up at the end of the session.
Is my screen visible?
Yes, it is visible.
And the PPT as well?
PPT nahi. Yeah, now I think you're the first slide.
Right. Now I think the slide is visible.
Yes, you can go ahead.
Okay, thank you. So yes, the topic that I am going to be speaking today is perioceutics, more than a prescription. Now, when Paul sir offered this opportunity to speak on this platform, he asked me for a couple of topics, and I gave him a couple of them, and then he promptly responded saying that I would like you to speak on this topic, perioceutics, because it's not very frequently heard of. And I kind of rationalized with him, saying that this is probably, not a topic that a lot of people would want to listen to. I'm not very sure. I had offered some other topics that I was probably more inclined to, but then now when I went through the entire material that and the research that I had to go through in order to put this lecture together, is when I realized that this was a great choice. And I hope y'all kind of agree with me when uh, we are done with this lecture. So the first thought that comes to your mind when you listen to this is this yet another fancy term? And, are we going to beat around the bush once again? And yet another topic for us to kind of memorize? Is this going to be purely academic? Is there anything related to practice in this? Well, let me get the basic of perioceutics, and then maybe we'll dissect it further. What is perioceutics? It's primarily the use of pharmacotherapeutic agents, right? Which includes both antimicrobial therapy as well as host modulation therapy for the management of periodontitis. So the next question in this case would be, isn't this HMT all over again? I didn't sign up for this. I mean, this is something that I have read about. There's something that I know. So what is new? What do we have to offer? Hear me out for the next few minutes. And I'm sure that you will have some newfound respect for pharmaceutical agents at the end of this topic, right? So why is this hype? Why am I speaking about this topic? What's the big deal about this topic? The first thing that we need to address is that mechanical debridement, as we all know, is the mainstay of periodontal therapy. We all know that periodontal therapy is primarily due to based on mechanical debridement. That is, we think about scaling and root planing as the mainstay of periodontal therapy. However, is this enough? We need to ask ourselves this question, primarily because we now understand that host response is a large determinant of disease progression, right? We will discuss this topic a little more in detail. I'm just giving bullets right now for us to ease into the topic. Host response, we all know, is primarily a major influencing factor in the way the disease progression occurs. We have learned sufficient amount of studies on this aspect, saying that why host response triggers a fulminant disease in certain individuals, whereas in many others the disease remains dormant or doesn't choose to kind of progress to a more severe form of periodontal disease. And if host response is a large determinant, then can we direct our efforts towards other evidence-based therapies which will help us to target this host response and try to alter it in a manner that would be favorable for us as periodontists when we provide treatment to our patients. And also we need to think about the fact that mechanical debridement is the mainstay, and we have had certain forms of periodontal therapy that we have been instituting for many years. But where do we see ourselves a few decades down the line? Are we going to remain the same kind of practitioners that we have been for several decades? Or are we going to probably introduce certain game-changing treatment modalities? Are we going to tweak something to our benefit? Are we trying to kind of push the envelope a little more so that we can change the outlook of periodontists and even general practitioners towards periodontal therapy? For that, the first thing that we as periodontists need to do is to look beyond stains and calculus. For how long will we continue to write stains plus plus, calculus plus plus, advice scaling? This is primarily, I mean, forgive me if I may sound too preposterous in saying this. I don't mean to say that it is just old school and we need to shove it under the carpet. However, it is imperative that we acknowledge the huge molecular aspect of periodontal pathogenesis. We find it in our papers every other year. I mean, every year, paper 2 of perio, that's etiopathogenesis, is full of questions related to the molecular aspect of periodontal disease. The problem is that somewhere it has remained academic and it is not translating into clinical practice. It is time that we change that a little bit and try and make that very change, which will probably change our treatment modality for the better. And we need to push the boundaries of periodontal therapy a little more so that we are not restricted to just doing this all our life, right? This is not where we see ourselves few decades down the line. We need to do something more, definitely. Now, coming back to the topic, let's visit some established facts before we dissect the topic further, right? We understand that bacteria are required in disease pathogenesis, and then we know about a whole lot of bacteria that are known to cause periodontal disease. We know them as the periopathogens. However, we also know for a fact that patients are not equally susceptible to the same kind of pathogens, and hence they do not respond similarly to the treatment. And we also understand that the host inflammatory response that is triggered because of these microbes is what is driving our immune mediated cells, that is the cell mediated self degradation that occurs in our periodontal tissues, which eventually may result into tooth loss, right? What is the conventional therapy in periodontitis? What do we do? What have we been doing for decades? What do we consider as an endpoint? And where are we probably going wrong, or where are we not directing our attention enough? Let's look at it one by one. What is the endpoint of periodontal therapy? We all understand this. Linde has made it very clear in 1982. The endpoint of periodontal therapy, any successful periodontal therapy, both long-term as well as short-term effects, will depend primarily upon disrupting the biofilm. That is, the supra and the subgingival pathogens need to be physically disintegrated such that there is no such biofilm that will trigger the further destruction of periodontal tissues. I have a small bone of contention over here, and that is that we now understand that periodontal pathogens are known to cause periodontal disease, but they are not the only factor that are present in the disease progression. And therefore, sometimes just elimination of periopathogens does not kind of switch off the alarm that we have set off in the form of inflammation, right? And what are the strategies that we are trying to that we are implementing in order to achieve this outcome. Obviously, the conventional strategies involve the use of non-surgical and surgical approaches, right? Non-surgical approaches involved are the various methods of disruption of the biofilm. We know about all of this, and eventually it progressed towards other concepts like full mouth disinfection, etc. Right? So this classical approach towards periodontal disease is definitely going to change in the future. And why am I saying so? Everybody who has appeared for the NUHS exams this year, the final year NUHS MDS exams this year, would have been kind of in for a surprise or shock when they saw questions on two topics that I have chosen to kind of mention over here. The first thing is the concept of personalized dentistry. I am also very happy to note that the forthcoming ISP conference is going to address this as the 5 Ps of periodontal therapy. So the concept of personalized dentistry is becoming increasingly popular. Now, when we speak about personalized dentistry pertaining to perio, we need to go into the omic approach, that is the oral microbiome and the proteome. We now know that the GCF and saliva is like this huge storehouse of information which gives us specific information about every individual specific microbiome and proteome, which will probably help us to target specific microorganisms and also help us to target specific host response events that are taking place in the host body, which will probably change the entire treatment modality of the periodontal disease in an individual patient. And therefore, personalized dentistry and personalized periodontics is going to be the future of our practice. Omic approaches, as I said, another question that had come in this year's paper was about the omic studies, that is the metabolomics, genomics, proteomics, and all of these definitely is a game changer. And in the forthcoming slides, we will understand why is this so different. Point of care therapy, we are aware of this as an academic term as of now, but we need to probably implement it at some point in time where some quick chairside diagnostic tests will be able to give us a detailed insight into the particular form of periodontal disease that the patient is suffering from, and a specific treatment modality can be formulated for these patients on the basis of such information. Now, what were the limitations that we were facing for over a period of time? We all know about this EPIC study that was conducted by Sokransky, where he divided them into complexes. And we know about the 700 organisms that he proposed are present in the oral biofilm, of which only 10 to 15 bacterial species were implicated in causing periodontal disease. However, I beg to differ. In the light of current information, we know much more than that right now. If you look at the recent publications that have come in Periodontology 2000, we look at more information coming in about more forms of pathogenic bacteria. Certain studies that were conducted using newer diagnostic techniques have brought forth a broad new outlook on periodontal microbiology. In fact, I was also pretty much under the same impression as what Sokransky enlightened us with several years ago, until I attended Dr. Rajiv Chitkubfi's lecture in an ISP MSG colloquium, where he kind of gave us a lecture which was an eye-opener of sorts, where we spoke about several new microorganisms that are now implicated in periodontal disease. If we look at them, the newer diagnostic techniques have helped us to kind of isolate those microorganisms and bring them to the fore, right? Now, when we look at this study of Sokransky, obviously it was transformative to the field. It changed our entire outlook. We knew about the red complex and the orange complex. We understood better about these organisms which are known to cause periodontal disease. But however, a major disadvantage here was the checkerboard DNA hybridization technique that was used by Sokransky has certain limitations. The first limitation in this case was that it is extremely sensitive to the sample input, that is the amount of plaque collected, and therefore it is extremely user sensitive, right? So the amount of plaque collected, the technique of plaque collection and all of that is going to influence the outcome of the study. Also, it only assessed the levels of 40 most common species of bacteria that are known to cause certain kind of oral infections. However, we now know that the periodontal pocket is typically known to harbor 5 times as many species, right? 16S sequencing has kind of changed our entire outlook and has eliminated all these limitations of checkerboard assays. If you look at it, it was the first study that investigated the oral microbiome using this technique. Itself revealed that a mind-boggling number of 19,000 phylotypes may be present in the human oral microbiota. Now, if you say that 15 out of 700 were known to cause periodontal disease, then can you imagine, out of 19,000 phylotypes that are present in the oral the microbes that are present in the oral cavity, definitely the number of periodontal pathogens is going to increase. And that kind of information has been brought forth, where we now understand that along with members of P. gingivalis, T. denticola, T. forsythia, which are known to be periodontal pathogens, that is, periodontal pathogens and health compatible species, as we all know, are known to coexist also in every oral cavity. However, along with these, certain newer pathogens were introduced, like Ephelosis, P. endodontalis, E. saphenum, P. abscessus. All of these have been known to cause periodontal disease in the recent past. So therefore, we need to change our treatment outlook a little bit, because we are not dealing with the same sort of microorganisms. We are now having more amount of information regarding greater number of bacteria that are known periodontal pathogens. We understand that every periodontal pathogen comes with its own unique ability to trigger the host. And therefore, with every new pathogen that is introduced, we are now probably going to encounter a newer form of host response. Every new form of host response is a newer technique for us in the form of host modulation therapy, in order to eliminate that host response and thereby help us to eliminate the inflammatory component of periodontal disease. Definitely, mechanical debridement is going to help us to eliminate the biofilm, or to disrupt the biofilm in a manner that the causative organisms are eliminated. But as I mentioned earlier, we need to kind of eliminate the trigger in the form of the host inflammatory response that is seen. And I'm going to be discussing that a little more as well in the forthcoming slides. What does this information mean for us? It means that we have a highly diverse oral biofilm, but our traditional periodontal therapy of scaling and root planing is extremely non-specific as we know it. And therefore, it consists mainly of mechanical disruption of supra and subgingival biofilms, as I mentioned earlier. However, when we find that these dysbiotic communities are developing, that is, whenever dysbiosis occurs, I'm sure that we are aware of this new term that has been in use in the past few years. As soon as dysbiosis is triggered, dysbiosis and destructive inflammation are mutually symbiotic with each other. They both feed each other with sufficient molecules that are required in order to flourish mutually. And therefore, this reciprocal relationship has to be broken at some point in time, right? And hence, I'm insisting that there is this unmet need as of now to complement our current therapeutic approaches of scaling and root planing and mechanical debridement with newer strategies that will address these destructive aspects of host inflammatory response. Only then can we probably hope to achieve a more holistic periodontal therapy for our patients and a more personalized periodontal therapy for our patients, right? Now, if you look at this, dysbiosis and the eubacteria, that is the eubiotic microbiota, I would like to kind of simplify this with an example. We have, let's say that we have two individuals who go about their daily rut every day. Both of them wake up at 6 a.m. Both of them head out for work at 8 a.m. in the morning. Both of them come back from work. They're all tired at the end of the day. And suddenly they find that they have a long weekend. Let us assume our healthy, let us assume that all of us, say we have periodontal disease, right? Person A and person B both have periodontal disease, both go about their daily lives every day. However, person A has more periodontal destruction as compared to person B. And why is this so? Why is person A suffering more than person B? Probably because the host response is more. Let us simplify this a little more. Two individuals go about their daily life. Suddenly they find that they have a long weekend. They decide to take a break, right? Both of them decide to sleep in for the entire long weekend, not do any kind of work. However, person B chooses to turn off the alarm. Person A does not turn off the alarm, which means that despite having a long weekend, despite having a day off, person A wakes up at the same time and has a very groggy morning again. The same thing applies to host response as well. Unless we switch off that alarm, despite getting a break or despite getting a long weekend in the form of scaling and route planning, or despite getting a break in the form of mechanical debridement, person A is not able to enjoy because his alarm never was switched off, and is going to be constantly irritating him. And therefore, unless we address this host response, which is going to be fed by the dysbiotic microbiota, there is going to be no successful elimination of periodontal disease, right? So we know that destructive inflammation and full-blown dysbiosis kind of have a positive feedback loop, which are going to feed each other with sufficient molecular messengers in the form of cytokines, or other inflammatory crosstalk, which will probably increase the destruction that is seen, right? And this is what brought about the IMPEDE model, which was proposed by Van Dyke, right? Inflammation mediated polymicrobial emergence and dysbiotic exacerbation model. We understand that there is going to be a dysbiosis. Polymicrobial dysbiosis occurs. However, unless there is an inflammatory mediator that is going to trigger this constant dysbiosis, there won't be a progression of disease. And progression and late stage periodontitis is definitely going to be mediated only by this inflammation mediated dysbiosis, and not by just the presence of polymicrobes in the oral cavity or polymicrobial emergence. And this brings us to the topic that is periosotics, right? Heska Corporation was the first to introduce the term periosotic. It would come as a surprise that Heska Corporation is actually a pharmaceutical company that deals with veterinarian medicine, right? They understood this concept, and we are still debating over it. I think it is time that we also come to terms with this reality, right? Veterinarians also probably have been dealing with the same issues with respect to their patients, and they came to terms with this concept that just mechanical debridement is probably not sufficient, and therefore certain pharmaceutical agents need to be used, and probably we need to take a leaf out of their study as well. Not that we have any insufficient studies. There are sufficient number of molecules that we have already studied. I'm not going to be delving into the details of all of these molecules, primarily because everybody knows about host modulation therapy. I'm just going to probably give you an overview of what we know and what we are probably looking at in the future. Right? Let's look at the oldest and kind of the pioneer of host modulation therapy. Golub gave us this tetracyclines, and we know that tetracyclines in their multiple forms are known as the primary host modulatory agents that were known to us, and they are known to us to be active in various different forms, right? We have understood that they are useful to us in the form of chemically modified tetracyclines. We know about SDDs, we know about local drug delivery of tetracyclines, right? We understand the faceted personality of tetracycline, their pleomorphic action, right? We understand that they help us in reducing the activity of MMPs. We understand that they also help to reduce osteoclastic activity, promote fibroblastic activity, promote collagen synthesis, reduce collagenase activity, and many such more activities. But let us look at tetracycline therapy. If we are going to change our practice and introduce tetracycline into our therapy, what do we need to consider? Do we have any studies in healthy as well as systemically compromised individuals? Because we are looking at a lot of systemically compromised patients these days, and it is these patients that probably need our attention even more as compared to healthy individuals, because as we know, diabetes is a double-edged sword for periodontal patients as well, right? So in healthy patients, it has been found that definitely tetracycline administration caused a much significant reduction in probing depths and improvement in clinical attachment levels, which was seen even more in case of severe disease. That is, in deeper pockets, it was found to be more effective as compared to in shallow to moderate pockets. And even studies which are conducted on a larger sample of subjects, like 209 and 227 individuals, it was found that there was significant improvement of probing depths and clinical attachment levels in the test group as compared to the control groups. I'm not going into the specific forms of tetracycline that we can use, because I'm sure that all PGs go through this over and over again. I'm only giving a more concise information regarding the various drugs that are probably available to us. right? We understand that periostat and such molecules are the gold standard when it comes to tetracycline therapy, because obviously it's the only FDA approved molecule that we are speaking about as well, right? But we are speaking about SDD here, where doxycycline administration was done by Mohammed et al., where significant improvement in probing depths and clinical attachment levels were seen. And also the EPIC study that was conducted by Prishaw, which described the efficacy of doxycycline along with scaling and root planing, right? But when we speak about systemically compromised individuals, individuals who suffer from diabetes, it was found that even these individuals showed significant benefit in the therapy by receiving SDD, that is subantimicrobial dose of doxycycline, because they showed significant improvement in PD as well as CAL. But not only these primary outcomes, that is, we are not only looking at the primary outcome of, say, reducing the pocket depth or improving the clinical attachment levels. As I said, we need to look at a more holistic approach, and that is in the secondary outcomes as well. That is, the patient doesn't come back saying that, oh, we have some bleeding while brushing, right? So we see this, that there is BOP also that is improved, that is bleeding on probing has also improved in such cases. And therefore, we are looking at multiple different forms of treatment outcomes. That is, we are not only looking at clinically visible outcomes for us, we are also looking at patient satisfaction here in the form of personalized therapy, where the patient comes back saying that there is significant improvement, not bleeding as much, right? And this is observed over 3 months of therapy. The next molecule, bisphosphonates. Again, as I said, bisphosphonates is a molecule that has been thoroughly researched upon, right? But do we use this molecule? SDDs, of course, we use. Tetracyclines, we use. In fact, most of the short studies that are conducted these days as a part of post-graduation are using any of these local drug deliveries of tetracycline, or even bisphosphonates for that matter. Metformin is another molecule that was studied, right? So bisphosphonates, we know about the various forms of bisphosphonates, the various groups, right? Alendronate, cilindronate, and all of these molecules that are used, right? We know that bisphosphonates have multiple sites where they act. They reduce the osteoclastic recruitment, and therefore they reduce osteoclast activity. They increase the apoptosis of osteoclast, and therefore bone loss is reduced. It is primarily a drug that is used in case of osteoporosis in order to improve the bone density, and therefore it was used in periodontal therapy as well.
Yeah, Ajit.
The connection is lost, I think.
Yeah, Ajit, are you there? Rajesh?
I will call him.
Just call him.
Yeah, he's joining back.
Okay.
Some technical issues. He trying to join. Try to join back.
Okay. Yeah, Ajit, you have joined back. Ajit has joined back.
Not yet.
Yeah, I can see him.
Okay.
Well,
Ajit,
Sorry about that technical glitch. I don't know. Suddenly it all went off. At what point did I disappear?
the last slide,
Bisphosphonates?
bisphosphonates, yeah.
Oh.
Bisphosphonates का second slide.
Right.
Yeah, it's very.
This slide?
The previous,
Okay.
yeah.
Right.
Correct.
Okay. I'll start afresh. So we understand that bisphosphonates have again multiple actions, and then they have been used primarily as local drug delivery therapy, right? We have a lot of research that has come in on bisphosphonates, primarily of alendronate that has been used, 1% alendronate gel that was used along with PRF, or it has been used along with graft material in order to improve the outcome of periodontal therapy. It has been used even during surgical periodontal therapy, right? However, everybody seems to have one primary issue with these studies. If you look at point number 2, most of the included studies were conducted in India. Most of these studies were probably conducted at GDC Bangalore. Dr. A.R. Pradeep sir has published a lot of papers on these local drug delivery systems like alendronate and metformin, etc. Simvastatin also. Right? So probably, and particularly in the same organization. So Therefore, a meta-analysis that I was referring to with respect to these drugs fails to give us a very straightforward answer, because they say that there may be a bias and therefore we need to look at RCTs coming from different parts of the world. Well, it's not our problem that the world is not looking at different molecules. I mean, we are at least doing some part of the work that everybody should be doing, I would say, right? So thankfully, we are having some studies which are being conducted in India, and it is heartening to know that even during, as I said, during short studies in post-graduation, there are a lot of local drug deliveries that are being tried in order to look at newer molecules that can be used in order to improve or tweak the host response to favor us in the outcome of periodontal therapy, right? In fact, bisphosphonates were also used along with dental implants, where they coated the surface of dental implants with bisphosphonates and found that the implants osseointegrate better and have higher survival rate than uncoated ones, right? I'm sure Mayur sir will also probably have a lot of information about this. I see his posts with PRF coated implants and many newer implant techniques that he commonly advocates along with his postgraduates. It's really encouraging to see those images as well, right? The next molecule, obviously, that has been used, abused, easily accessible to all of us, non-steroidal anti-inflammatory drugs. No patient leaves the department without a prescription of some NSAID, right? And it has been backed by a lot of people. But are we following the crowd, or is this an evidence-based practice? It will be unfair if I just try to paint a rosy picture about all of these host modulatory agents and, kind of push all of them or hard sell them, saying that, oh yes, you should use tetracyclines and some antimicrobial dose of doxycycline, use bisphosphonates, NSAIDs, all of this. Where is the evidence-based practice? What does that tell us, right? And unfortunately, I wouldn't be one to suggest this, primarily because any response that is elicited by NSAIDs is limited to the time for which the patient takes the NSAID. There is no long-term action of the drug that is seen. There is no such modification of the host response that will persist over a period of time. We are only modifying the host response during the administration of the drug. We are not changing the host response in a manner that a new normal, as they say, is achieved by the host response. And therefore, if you look at the study, a cyclic regimen with 50 milligrams of diclofenac potassium for 2 months, followed by a 2-month washout, and then 2 more months of treatment, I already have a hyperacidity response after looking at this study. The patient was subjected to 2 months, followed by 2 months washout, and then 2 more months of treatment compared to a placebo. And you tell me that there is PPD reduction. Obviously, there is PPD reduction. But is this something that we would administer to our patients? I don't think so. And therefore, we need to look at probably certain therapeutic modalities which are more realistic, which are probably more implementable, and not look at just something that would kind of appease the patient and the operator only for the near future. Like if I administer NSAIDs for 5 days or 7 days and then do a recall after 2 weeks, obviously it is all going to look hunky-dory. But how does it look 6 months later? Is the patient going back in time and showing periodontal destruction again because the inflammatory response is back? Or have we been able to kind of maintain a healthy immune response in this patient, is what we are going to be looking at. And therefore, NSAIDs is a no-go for me, unfortunately. Anti-cytokine therapy, a very commonly asked short answer question in our papers. I'm sure a lot of people are going to be screenshotting these slides, right? The various forms of anti-cytokine therapy that are known to us in the form of receptor antagonists or cytokine antibodies, or soluble cytokine receptors, which will kind of prevent the binding of the cytokines and thereby prevent the signaling of these cytokines. We know a lot of these. One name would probably be very common, or one name would be very popular, and that is an anti-cytokine antibody, that is an IL-6 antibody called as tocilizumab, that was kind of infamous or infamous during the COVID pandemic. Right, tocilizumab was something that every layman knew about, right? Do we see ourselves using any of these in our clinical practice? As I said, I'm not going to be hard selling any of these drugs. I'm going to be realistic and try to give you both sides of the picture, right? We are not. And let me tell you why. The only human study that I could find out of any of these cytokine therapies that are probably suggested to us as of now is that of infliximab that was used in patients who had periodontitis, but they were already suffering from rheumatoid arthritis. Infliximab is a drug that is used in the treatment of rheumatoid arthritis. It was noticed that patients who were suffering from rheumatoid arthritis and chronic periodontitis did not undergo any therapy, but showed improvement in their periodontal parameters because they were receiving infliximab. But can I give infliximab in healthy individuals? No, I can't, because of the multiple systemic complications that these drugs come with. If you can give me any form of these cytokine inhibitors or anti-cytokine drugs, which can be locally acting and thereby prevent the crosstalk between all of these inflammatory cells in the local environment of the periodontium, maybe I'll buy that argument. However, I am not administering any of these drugs without proper medical surveillance, or I am not risking administering any of these drugs to individuals who are healthy and probably do not need this because they may result in many other systemic complications, including a fulminant infection, by reducing the immune response by eliminating the cytokine action. So increased risk of microbial infection is probably one of the most common side effects of any of these anti-cytokine therapies, which was probably even encountered in patients who received tocilizumab. And we saw many patients who were eventually being treated for mucormycosis after receiving such kind of anti-cytokine therapy. So all of these drugs, as of now, remain purely academic. However, we hope that in the future, we will look at some such drugs which will be locally acting, which can be introduced into the local periodontium and therefore produce a change in the host immune response within that particular area. The next molecule that I'm going to be speaking about, probiotics, yet another exam favorite these days. Examiner favorite also. A lot of people ask about probiotics in periodontal therapy. We know about prebiotics, probiotics, and these molecules are quite commonly heard of, but do we know more about these? And to simplify it, what does a probiotic do? A probiotic is a microorganism that is going to be introduced in the midst of all of these pathogenic species, and it is going to compete with the pathogenic species for various things, including space to live, food to eat, all of that. And at the same time, it will increase certain antibacterial compounds which are active against these pathogenic bacteria, right? So these are the direct actions of probiotics. What are the indirect actions of probiotics? Obviously, probiotics are known to improve our immune system. We are going to look at how are we going to change a hyperactive immune system, which gives an increased inflammatory response, to a healthy immune system, which gives a moderated and a more controlled immune response, which will probably result in only as much inflammation as is needed in order to reduce the action of these microorganisms, or in order to alert you that there is a problem that you need to deal with, right? You want bleeding on provocation so that the patient realizes that there is some amount of problem in my gums, I need to address this. But you don't want it to bleed so profusely that the patient bites into an apple every day or takes a bite into any form of food and then has bleeding from gums constantly, right? Some studies related to probiotics published in Perio 2000 2021, a very recent publication, which shows the various forms of probiotics that are available to us. Yeah, lactobacillus being a very common form of probiotic that is used even in periodontal therapy, not only as a drug that is used for the gut or healthy gut, it is also used in periodontal therapy. Lactobacillus rhamnosus has been shown to have uh, a decent amount of antimicrobial activity where it promotes the level of green complex, that is, it promotes healthy bacteria in the form of streptococci-like species, while it reduces the periopathogens in the form of Capnocytophaga or Echinella corridans or P. intermedia that are known to cause periodontal destruction. At the same time, That is on the microbiological level. But if you look at the immunologic response, we find that there is a decrease in the expression of OPG and beta defensins. This will definitely act on the rank-rankle OPG axis and therefore help to reduce the osteoclastic activity and therefore help to reduce the amount of bone loss that is seen in periodontal disease. Right? We also find significantly fewer trap-positive osteoclasts, which will be extremely active and they're going to eat away into a lot of bone, and they're going to form a significant increase in anti-inflammatory cytokines. We know that cytokine crosstalk is important. We know that there is going to be some amount of molecular signaling that is happening. But what kind of molecules do we want in this? We want the anti-inflammatory cytokines after a particular point in time in order to reduce the hyperinflammatory response, in order to reduce the number of primed neutrophils that are going to eat into all of the collagen that is present in our periodontal tissues. Right? Again, a few studies which involve Lactobacillus brevis, Lactobacillus rhamnosus, Bifidobacterium, all of these which are known to produce some amount of improvement in the periodontal parameters, not by themselves, definitely with the help of SRP. They are only as an adjunct. We are not looking at probiotics as a monotherapy. We are only looking at them as an adjunct to scaling and root planing. As I said earlier also in this lecture, I am not saying that mechanical debridement is not the mainstay. It is, and it will remain so, because we need to disrupt the microbial colonies. However, we are only looking at supplementing our therapy with something which will take care of the other end of the spectrum, that is a hyperinflammatory response. Right? Now, this is again from a systematic review and meta-analysis that was conducted, where it was found that there is a moderate improvement in the periodontal parameters when probiotics are used as an adjunct to scaling and root planing. Right? Now, what did the meta-analysis say? What is the primary outcome and what are the secondary outcomes? As I said, primary outcomes that we are going to see very visibly, that is, there is going to be a reduction in the probing pocket depth. There is going to be a gain in the clinical attachment levels. However, we are also looking at a significant reduction in systemic inflammation. Right? Now, probiotics, thankfully, are molecules which can not only be administered as local drug delivery, they can also be administered systemically, because we know that there is very minimal amount of side effect, if any, that will be caused due to administration of probiotics. So this is one molecule that should probably replace NSAIDs on our prescription pads, where we randomly prescribe a lot of NSAIDs with only limited action and limited duration of action. Probiotics are probably a healthier addition to our prescriptions, where they are known to downregulate inflammation on a systemic level, and therefore that systemic inflammation, when it reduces, obviously it is going to reduce in a more holistic manner, and therefore the periodontal inflammation is also going to be reduced. The inflammatory response that is elicited in the presence of periodontal pathogens will also be reduced and will remain so after the elimination of the periodontal pathogens with mechanical debridement. Right? So we find that a lot of chronic inflammatory conditions, the patients are prescribed probiotics. Periodontitis is also a chronic inflammatory condition. May not be a systemic chronic inflammatory condition. However, it triggers the same kind of inflammatory response in the periodontal tissues, and therefore the use of probiotics is definitely advocated. We may look at small steps right now. We may see certain molecules which are kind of giving us, a response that is not excellent. If you look at a meta-analysis, they say that there is decent evidence, there is low evidence. We don't find anything which says that there is excellent evidence that use of probiotics is going to improve the use or going to improve the outcome of periodontal therapy. But I say these are baby steps. Unless we start making some changes, unless we start doing some kind of research into all of these molecules, how will we ever come across certain newer molecules that will help us to change the outlook towards periodontal therapy? Yet another newer entrant is complement inhibition. I'm sure every postgraduate student, right from the first year of post-graduation, is very familiar with this flowchart, this crazy flowchart that explains the various pathways of the complement activity when it comes to an inflammatory response. We know about the various types of inflammation and the various inflammatory responses in which we have to probably explain complement also at times, and it's extremely confusing. But let me simplify this for you, or let me draw parallels for the seniors who may have forgotten basic science to a certain extent. I mean, senior postgraduate students, you look at it, gingipanes, a very commonly asked question. You know that gingipanes acts on the C3 complement, and it triggers the cascade by causing it to split into C3A and C3B, and therefore the entire convertase chain begins, leading to inflammation again, right? If by some means we can inhibit this, that is, we can prevent the complement cascade from leading towards inflammation, that is, by preventing the convertase enzyme, by preventing the breakdown of C3 into C3A and C3B, we may probably be able to limit certain forms of inflammation, or certain, you see, inflammation is acting in a multifactorial manner. It is not just complement, it is acting through cytokines, it is acting through macrophages, through mast cells, through neutrophils, through MMPs, right? Through interferons, through interleukins. So if we can probably somehow eliminate one small part of it, that is, we take away complement, then we may probably be able to achieve better outcome of periodontal therapy. Now, again, unlike a lot of other things, like we said, anti-cytokine therapy, bhi to bola tha, par wo to kuch hua nahi, that turned out to be entirely academic. C3 bhi kya hi hoga, it was going to be probably academic. I beg to differ. We now have a C3 inhibition molecule, which is called as CP40. And this CP40 is a strong anti-interleukin 17. That is, it is going to inhibit the action of interleukin 17, which is a major pro-osteoclastogenic cytokine, right? So if CP40 is going to be introduced in the local periodontal environment, then it is going to inhibit interleukin 17, IL-17, which will thereby directly cause a reduction in the osteoclastic activity and thereby prevent bone loss in this. But do we have CP40 as a molecule? I'm happy to report that CP40 has been licensed by Amendus Pharmaceuticals, and we have had studies in human clinical trials as well, where CP40 was, for now, we are looking at systemic administration in order to see if there is any systemic side effect of administering this drug. So subcutaneous and IV route of administration of this CP40 has already been tried in the form of a molecule which is marketed as AMY101, and it has found that it was safe in the human trials. It is not too far into the future where we may find that there may be a local administration of this molecule which will help us to inhibit the complement form of inflammatory response and thereby prevent osteoclastic triggering due to interleukin 17. So this is something that new drug that I have to offer here in the form of CP40 or AMY101, apart from the probiotics, of course. What are the SPMs? Specialized pro-resolving mediators. We know them as various molecules like lipoxins, resolvins, protectins, marasins, etc. They are all derived from polyunsaturated fatty acids, right? Now, all of these are regulators of inflammatory process, but there is it is found that all of these molecules are excellent in they are excellent in those places where there is no immunosuppression happening. That is, there is nobody to regulate this immune response. In such cases, all of these molecules are known to cause some amount of immune regulation, where there is a reduction in PMN infiltration, reduction in the reactive oxygen species production. We now know that oxidative stress is probably one of the leading causes of cell death because of increased ROS activity. We find that every cell has a mitochondria. Mitochondria, we all know, powerhouse of the cell, and it produces a large amount of energy. But every time the mitochondria goes through the terminal oxidation, some amount of reactive oxygen species is going to be produced. And in case of inflammation, where the cellular activity is going to be increased, there is going to be increased mitochondrial activity, increased production of reactive oxygen species, which is definitely going to cause an increase in the oxidative stress and thereby tissue destruction. Obviously, whenever there is increased inflammation, there is going to be increased cytokine generation. All of these things are limited by introduction of molecules such as lipoxins, resolvins, marasins, etc. In fact, resolvins has newer molecules as well in the form of REV-E1, right? All of these are tried and tested nowadays in the local environment also, where it has been tested in patients suffering from localized aggressive periodontitis, where it was found that the neutrophils of localized aggressive periodontitis, which we call as the primed neutrophils, which are hyperactive neutrophils, which cause tremendous amount of collagenolysis, right? All of these individuals which were refractory to many anti-inflammatory molecules were responding to the resolvin E1 molecule. So the resolvin E1 molecule is probably a newer molecule that is of promise, where we can find that if it is able to act in obviously an obsolete term, aggressive periodontitis, but if it could act in such a condition as well, where the neutrophils are absolutely rogue neutrophils that don't listen to any other anti-inflammatory molecules, if they responded to the resolvin E1, then definitely it is a molecule of promise where it can be used in the future. Similar such molecules are known as omega-3 fatty acids, which we will come to eventually. But there are many studies. Again, I have quoted these studies from a meta-analysis again, that it is found that these SPMs like lipoxins, resolvins, etc., they prevent alveolar bone resorption and regenerate lost bone because of reduced periodontal inflammation. So we see that it is not only about reducing inflammation in order to limit the amount of bone loss, it is also limiting the periodontal inflammation in order to change it to a more healthy immune response, where we are going to improve the osteoblastic activity, improve the collagen production, improve fibroblastic activity in order to make a more healthy periodontium in the future, and not just eliminate the activity of the periopathogens, right? Omega-3 fatty acids, again, these are all related molecules: lipoxins, resolvins, protectins, merasins, etc. All of these are other forms of omega-3 fatty acids which are known to help in periodontal therapy. Again, another slide which is taken from a meta-analysis, where we have polyunsaturated fatty acids that are used, which many RCTs have quoted. El-Sharkawi is probably one of the pioneer in the studies of omega-3 fatty acids. There are Perio 2000 studies, studies published in Perio 2000 lately. We have articles which are published by Golub et al. In 2021, which are promoting the use of these molecules, where omega-3 fatty acids are known to improve the outcome of periodontal therapy. Again, I must reinforce that all of these molecules were used along with mechanical periodontal therapy or with mechanical debridement. They were not used as monotherapy. And it has been found that there is significant improvement in not only the primary outcome that we see in the form of periodontal parameters, that is probing pocket depth or clinical attachment levels, it has also caused other secondary outcomes in the form of reduction in CRP, reduction in the interleukin 1 beta levels, improvement in the superoxide dismutase activity, which kind of reduces the oxidative stress. So all of these are more promising molecules which can be easily used in the future, right? The names of some omega-3 fatty acids, icosapentaenoic acid and docosahexaenoic acid, these are some omega-3 fatty acids that can be used. As I said, primary outcomes, secondary outcomes that I've already discussed, improving the endpoints, that is pocket depth and clinical attachment levels, but it also improved cytokine levels, which are anti-inflammatory cytokines and pro-health cytokines. Quickly just going through some molecules which are not being used extensively, but you have some molecules like melatonin, which have been used in certain studies. Melatonin was used along with vitamin C because of its anti-inflammatory property. We know that melatonin is found in saliva and GCF also. It has been isolated in both of these fluids. We know that it improves VEGF expression, which is a potent angiogenic modulator, and therefore there is going to be increased angiogenesis. Therefore, healing is improving, tissue healing in the form of osteogenesis, which will require a lot of angiogenetic activity. All of that improves, and it has a positive effect of on monocytes and fibroblasts, and therefore it improves the holistic periodontal health and not just limit periodontal destruction. Right? As I said, melatonin was administered along with vitamin C. The dose has been specified over here: 2 milligrams of melatonin, which is administered per day for 4 weeks. And a benefit of giving melatonin is also that it kind of regulates your circadian rhythm, and therefore patients will sleep more soundly. They will come back to your office more refreshed and say that I'm less stressed, sleeping well, feeling better, my gums don't bleed anymore. Yeah. So melatonin, along with again NSPT and vitamin C, varying doses for females and males. As we all know, these are micronutrients which are required in different quantities. This was a study that was published in 2017. They found that there was reasonable effect. However, there was some challenge where 3 months versus 6 months, the difference was not always the same. However, again, as I said, unless we start somewhere, we won't end up anywhere, right? So unless we start looking at these molecules and start researching on these molecules, we are not going to end up with any newer molecules, right? So in conclusion, let me just summarize what we have discussed until now. That we know that we need to look at more biologic mediators, and we need to target some specific components of the immune response. We need more targeted molecules, which will probably look at only the neutrophils, which will target the MMPs. We already have SDD, which will target the osteoclastic activity. We have this phospholipids, which will target reactive oxygen species. We have probiotics, which will target the fibroblastic activity. Again, we have tetracyclines, right, which will target VEGF. We have melatonin, which will. So we have a lot of these biologic modulators which are targeting the specific components of immune response. Maybe we don't have drugs which are readily available. Maybe we don't have drugs which can be easily administered. Maybe we don't have long-term studies of these molecules. But as I said, unless we start somewhere, we are going to end up nowhere. Right? If we remain with the same concepts of only scaling and route planing and administer chlorhexidine and to mask the effects of everything, prescribe NSAIDs for a week, we will probably not achieve what we are setting out to achieve. That is a more holistic periodontal therapy, where when the patient comes back to you after 6 months, you're able to maintain the outcome that you achieved in the first month of periodontal therapy over a longer period of time, where the patient comes to you not in disease, or patient comes to you not with a complaint, but the patient comes to you happily saying that I've just come for a recall because I still feel great. I just want to see if everything is normal, right? So we understand that there are certain targeted approaches that are available in order to inhibit the progression of periodontal disease to a late stage periodontitis. The challenge that we are facing as of now is to clinically evaluate all of these drugs in their risk as well as benefits. And I'm glad that I'm addressing this audience today, because this audience comprises of such a large number of PG students, because the onus is on you guys who have a ready access to so many patients. Your sample size as compared to a private practitioner is so much more, where you all have the chance to try out these newer molecules and them. And we have more such meta-analysis which say that all of these studies came in from India, and we need more such studies from across the world in order to be able to generalize something. It's okay if all of the publications are coming from India, but at the same time, I would like to add a word of caution. Do not conduct a study with the result in your mind. Do not conduct a study on any molecule with the bias saying that अभी कर रहा हूँ study तो फिर outcome तो अच्छा होना ही चाहिए. It is okay to have a negative outcome. Like I just said with NSAIDs, it is okay to say that I'm not going to prescribe an NSAID to a patient for 2 months at a stretch, and I'm not going to give diclofenac for 2 months. It's fine to say that. But unless we begin to look at newer molecules, we're not going to be ending up anywhere, right? So as I said, our understanding of periodontal pathogenesis has changed every year. And it is very evident in the essay question of periodontal pathogenesis. We have so many models of disease progression and so many models of periodontal pathogenesis that we keep quoting. First, we came up with specific, non-specific. We came up with so many newer theories, came up with keystone pathogen. Now we come with the PSD model. Now we have come up with the impede model. So periodontal disease pathogenesis understanding is an ongoing process. Then why can't the periodontal therapeutic management also be an ongoing process, where we keep looking for newer molecules in order to address our problem, right? But as I said, it is imperative that we understand that the benefits of prescribing must always outweigh the adverse effects of the drug, right? The key limitation in this case is the gap of knowledge that we have between short-term evidence and long-term use of this drug, right? If it is something like a probiotic, which I feel that the benefit is definitely outweighing the adverse effects. It is imperative that we have some long-term studies which will help us to kind of establish whether these are drugs that can be introduced in our practice, or which are a easy introduction into our practice as compared to anti-cytokine therapy, which still remains as a distinct. Right. With that, I'm done with my bit of speaking. I'm sorry. I'm sure I overshot it a little bit, and the technical glitch in between didn't help. But I hope it wasn't a boring talk, and that I was able to bring your attention to certain newer molecules as I intended it to be, and help you look at host modulation therapy in a newer light as compared to what we generally do as academicians. Thank you very much. I would like to thank ISP once again. Thank Paul sir, Gaikwad sir, Varsha Rathod ma'am for being so kind in her introduction. All the postgrads and all the attendees who have been patiently hearing me out for the past entire duration. Also, I would like to thank my guide, Dr. Janak Kapadia, and my mentor, Bheras Gaukar ma'am, who brought me to a position where I'm able to be on the other side and able to speak and share my thoughts. Obviously, I must thank the college that I'm currently affiliated to, IMT Dental College, for giving me a platform to share my knowledge with the periodontists and budding graduates of dentistry. Thank you very much.
Thank you very much, Dr. Ajit, for an excellent presentation on a newer topic. And you have really highlighted us and the newer generation that what are the different treatment modalities which we want to look upon henceforth. It's not only the surgical part, but definitely try out newer molecules. Students nowadays are in a dilemma to hunt for a good dissertation topics every year. And you have given us a very wider outlook on how we can change our perception in doing the research. And as you rightly said, that yes, you need a longer term studies, wherein the students, the PG students can continue their own studies, for the later years also. That is what I understand. So any questions from the audience? I already see in the chat box, Ajit, you have ample of applause from your guides, senior teachers, and my fellow colleagues, Poonam, Dr. Sangeeta Muglikar ma'am, Dr. Bedaskar madam. Everybody has appreciated your spreading of wider knowledge on today's topic. So I thank you for joining us today and accepting our invitation to please address our audience today, and we surely look upon you to keep calling you for the future endeavors also. Thank you, Ajit.
Thank you so much.
Thanks a lot. And without wasting much time, let us move ahead to our next keynote speaker, whom Dr. Dilip Pol sir has rightly said that he is the celebrity of our fraternity. And I see a wide smile on his face, and I'm very happy to see it, Mayur. I have never met you. Today I'm seeing you for the first time on screen. But I have heard a lot of applause for you. I am a part of Perioheads group, ISP group. You have been uploading n number of YouTube videos on simple techniques of suturing or implant therapy, and they are so helpful for the younger generation nowadays. It's such a nice feeling to see that somebody is really taking our branch to the higher levels. Apart from this, I recently heard about your tour to the implant factories, which has never been, I think, taken over in any of the branches also. Finite element studies, yes, they are done, but the students are not made aware practically, physically, how it happens. So, Mayur, you are really a step go for the newer generations, and they really look upon you. And I'm sure that Perio branch, which was actually having a shortfall of not completing the seats or so, but now henceforth people are actually looking out to it with your newer perceptions, and you are also guiding us as senior teachers how we should bring our PGs to look upon our branch. So thank you for accepting today's invitation for addressing our audience of Maharashtra Mumbai Study Group. Sorry. So as I would like to say that Dr. Mayur Kaushik is an alumni of Manipal, he got his BDS degree from Manipal Dental College, and later he went ahead to pursue from Government Dental College, Nagpur. So we can proudly say that he is a postgraduate alumnus of Maharashtra and Government Dental College. So and after that he has joined Subharti Dental College in Meerut, and he's been a faculty of this prestigious institution of our country since last 16 years. And presently he is working as a professor and head of the department. And the PGs are very privileged to have him as his guide and teacher. Apart from his applauds, he is also having a recipient award of DN Kapoor, that is International College of Dentists, and has around 51 national and international publications to his credit. He has also co-authored 14 books of our specialty. That is really very good. And he has supervised more than 60 research projects till date, including the postgraduates and PhD, I suppose. He's been running an implant-based practice since last 15 years in his hometown Meerut, where he's currently practicing and working at Subharti. And he's also working as a course coordinator and mentor at Rochelle Implant Training Center in Meerut. So I welcome you, Dr. Mayur Kaushik. Please enlighten us and my dear students who have joined today with your topic. Thank you.
Thanks a lot, ma'am, for the kind words, ma'am. Humbled, honored, ma'am. It is an honor for me to be on this platform. I'll just try to share the screen once. And I think it is visible, ma'am. So, are my slides visible, ma'am?
Yes.
So, I'll straight away start with the topic, ma'am.
Yes.
Jai Hind to everybody. It is an honor to be on this platform. I bring to you greetings from Swami Vivekanand Subharti University, Meerut. As ma'am showered her appreciation during my intro, I've been working in this university for quite some time. In April this year, I completed 17 years in this university. And just a small intro about our university. It is a huge university, ma'am. Like it is a mini city in itself. It has 20 separate colleges under its wing. So it is a huge university that we have. I've been working in this college 17 and a half years now, ever since I completed my post-graduation from GDC Nagpur in 2005 April. And whatever I am today, it is because I had a godly figure as a guide during my post-graduation, Dr. R.K. Eltiwar sir. So we call ourselves part of Eltiwar sir's family. So sir's blessings have been there with us all along, and that is the thing which has actually kept us going, ma'am, throughout. And I'm currently heading the Department of Odontology and Implantology in our college. This is our cubicle system, ma'am. Like we encourage the PGs to actually design the clinics, the cubicles, as if they were their own clinics for the next 3 years as such, just to create a positive impact. Rochelle Implant Training Center is where we actually train right from an intern to postgraduate of any other specialty to a practitioner, whoever wishes to join. This comes under Lokpriya Hospital of Subharti Group. So Subharti Group has the biggest hospital in Meerut city. And in that hospital, we have this academy. Dr. Rohit Ravinder is the director. He is an endodontist, the owner of the hospital. And again, I say implant is an interdisciplinary field. So in an interdisciplinary field, along with me, we have Sumit Makkad, who is a professor in prostho, and Prajesh Dubey, who is a professor in oral surgery. So Prajesh has been one of my first batch of students. When I had joined Subharti, he had just entered his final year of BDS. So I've taught him as a teacher during his undergraduate time also. And ma'am, this academy basically is not a separate academy which is away from the institute. Rochelle actually is short for Dr. Rohit and his wife, Dr. Shalya, who is the CEO of Swami Vivekanand Subharti University. So this is where we teach implants to anybody who couldn't learn implants during PG time or during BDS curriculum as such in an ethical manner. And I run this clinic, Kaushik's Dental Care, where I practice with my father, who is a general dentist, Dr. K. Kaushik, and my wife, Dr. Nupur Kaushik. She is a pedodontist. She's a pedo professor in Subharti only. I joined Papa in 2005 in this practice. He has been there. This is a small world, ma'am. My 11-year-old daughter, Adya. So starting with the topic, ma'am, it is a real honor. I'm really honored uh, that Paul sir, Rajesh Gaikwad sir, you ma'am, thought me befitting of this honor that I could speak on this platform, ma'am. And it is an honor to have the ISP president, secretary also with us here. So it is a real honor. Paul sir was my external examiner during my MDS examination. So the degree also partly I owe to Paul sir only. So starting with the topic, ma'am, periodontal surgical considerations in implantology. We have had a very extensive, very knowledgeable session from Dr. Ajit. So I'll try to keep it as short as possible. Few clinical tips and tricks I'll try to cover up in the next 20-30 minutes or so. So with regard to periodontal considerations, I always say that all of us are general dentists first, specialists next. And as dental surgeons, we are supposed to be the smile architects of our patients. And one thing which completely destroys the smile is a missing tooth. So gone are the days when RPD used to be given. Now nobody wants an RPD, frankly speaking. And there was a time way back in 2005 when I started my MDS practice in Meerut, where the success of a practice was actually determined by the number of FPDs a person was delivering in a month. Now is the time for only implant. And the success of a practice, the fame of a practice, everything is determined by, everybody just wants to put implantologist in front of their name, no matter whether they are endodontists, prosthodontists, etc. So the thing about implant that I want to convey to all the budding periodontists, to all the students, is that in implant, the prosthetic component, the crown, comes much later. It is the surgical component, that is the implant has to be placed surgically in living tissues, that is bone and soft tissue, which comes first. So if the surgical component is poor, the prosthetic component is bound to fail. So this is one thing which has to be clear in our mind, that the reason it was removed or not just put in a non-surgical branch, that is prosthodontics, is because the surgery is the base of implantology. So the world over accepted definition of implantology is prosthetic driven surgical treatment modality. So what that means, that as a periodontal surgeon or as a dental surgeon, unless and until our IRS is strong, we can never be a good implantologist. And that is incision, reflection, and suturing. That is something which has to be strong. Otherwise, we'll end up cases like these. The implant has survived, but it is an aesthetic failure. So when we talk about periodontal surgical considerations in implantology, there are 5 basic things which superficially I'll be going through, which superficially I strongly emphasize that as perio PGs, all of you should be doing ample procedures of these 5 aspects about implant in your PG curriculum. The first thing is guided bone regeneration. So guided bone regeneration, again, the dilemma which I face as a practitioner is the patient who has ample bone generally doesn't have money to pay for an implant. And the patient who doesn't have bone will be telling doc, take any amount of money, just give me fixed bone. So ultimately, some amount of bone regeneration has to be done with regard to each and every case of implant. So what exactly is this guided bone regeneration? So from an examination point of view, again, the GTR part, 2 studies, 2 pioneer authors are very, very important. They are the ones who actually gave this concept. Melcher gave the concept of differential cell proliferation. And finally, Neiman, Karing, and Linde, they were the ones who actually established the clinical procedure. Same way with regard to GBR. 2 studies we are supposed to remember, pioneer researchers, as Dr. Ajit always said, that basically the pioneer authors should be respected. So here, Galen was the one in 1988 who gave this concept, and Boozer was the one who actually established the procedure. And now the procedure has become a reality. But the important thing is, other than this pioneer thing, we are supposed to be aware of how to do this procedure. So this procedure can be done at various steps of implantology. For example, this particular case of mine had come to the department. So known patient, so I had called the patient to the college so that I could demonstrate to the PGs also. And this is a procedure that we do routinely. But documentation I'm presenting of this case. So in this case, in the CBCT, the bone was too thin. We wanted to place a 4 millimeter implant, but at the narrowest point, the entire thickness was just 4.2. So ultimately, we had to go in for bone regeneration prior to implant placement. So here is GBR prior to implant placement. So the procedure which all of you have to keep in mind is that firstly, we have to give a mid-crestal incision, and then we have to reflect the flap. Once the flap was reflected, this is a thing which I always emphasize. Always use a round carbide burr and do cortical perforation. The advantage of cortical perforation is intramarrow blood will be coming there with osteoprogenitor cells, and your regenerative results would be enhanced. Now, after this, you are supposed to place a membrane for retention of the bone graft. Now, the problem with membranes that we face is that resorbable membranes basically don't have strength. So the moment you spend time in manipulating it, putting it, the size is not fitting, then we have to remove, then again trim it, the entire membrane starts disintegrating, it starts getting crumpled as such. So that is where I always advocate a simple Macintosh sheet, which is sterilized. So a dumbbell shape can be created in the Macintosh sheet. Couple of times we have to do it, and then a final shape according to your defect would be there. Please make sure that we use this thing first, dear students. Once that is made, now we are ready to open up the packet of our membrane. So membrane, again, India is a cost sensitive practice. So we can go in for periocoll or any collagen membrane if we can afford expensive membranes also. Otherwise, anything which is in the range of this 1400 rupees membrane. Now this membrane has to be trimmed according to the Macintosh sheet template that we have prepared. So here I'm trimming it, and once it has been trimmed, now it is ready to be placed in the oral cavity. But there is an issue. This membrane is supposed to serve as a retentive device for the bone graft underneath. But the issue is, if I place my bone graft here, the entire graft will be displaced in the apical direction. So this part has to be stabilized. The upper part has to be stabilized with a membrane tack kit. This is my membrane tack kit, hardly 6,000 rupees. And we can go in for any membrane tack kit. So three components of membrane tack kit have to be clear in our mind. We have the mallet, we have the membrane placement instrument, and we have the tacks, the membrane stabilization tacks. So tack is like a nail. This is different from a screw. So tack is something which we can simply punch inside. So tack pin is like this, which we have to buy. And a tack placement instrument is basically an instrument by which we actually can pick it up and then apply it at 90 degree. I'll just demonstrate, and then tap it with your mallet. So these are photographs from a preclinical exercise that we conduct in the department as part of first year PGs on GBR. So in GBR, we're supposed to pick up the tack and then employ it at this area. So can you see 90 degree? We are supposed to tap the tack inside. And now I have placed that tack in the patient as such. So in the apical part of the membrane, the tack has been placed so that the membrane is stabilized from that area, and none of the bone graft, not much of the bone graft can flow into the periapical area. The next step is now you have to use your bone graft carrying instruments and your condenser for putting bone graft underneath the membrane. So this bone graft, again, as ma'am rightly said, I am an alumni of Maharashtra. So the first time I had used the Tata Memorial bone graft was 20 years back, ma'am, in the year 2002, first year of PG. And that is when my Mumbai seniors, I had many seniors from GDC Mumbai, Dr. Abhijit Gurau, Dr. Nishant Vaishnav. They were very big fans of this bone graft. And I've been using these bone grafts for the last 20 years now. And straight away, all of us from Maharashtra at least can vouch for these bone grafts. So these bone grafts are very economical. And once mixed with the graft, with the blood, they have to be carried in the bone graft carrier syringe. And this is how they are supposed to be condensed underneath the membrane. We have to lift up the membrane adaptation, membrane tack placement first, then placement of the bone graft. This is the sequence which has to be followed. So now I have lifted the membrane and I am condensing the bone graft, putting the bone graft underneath the membrane. So once this has been done, this is the bone graft which is condensed. Now what we have to do is we have to put the membrane back. The palatal side, no need of placement of a tack is there, because the palatal side would be stabilized by the flap itself, plus all the bone grafting that we are doing is on the buccal side, because generally the buccal cortical plate is left. And the most important thing is primary closure. Now, this is where I see non-surgical specialists struggling like anything. They'll be placing gingival former over an implant directly. They'll be using flowable composite. No, this is an absolute necessity. Passive closure, you have to give vertical incisions for that. But after that, passive closure has to be there, because as said by Wang and Boyapati in 2006, that 4 principles of successful regeneration are primary closure, angiogenesis by cortical perforation, we have stabilization, and finally space maintenance. We have to ensure that whatever surgery, periodontal surgery we are doing, ensures these principles are followed. And if you have these principles, this is the result which is obtained. So implant we placed around 5 months later on, ample thick bone formation was there. Rather, we had a hard time locating the tack. So tack was completely covered in bone. And then finally, a Maryland prosthesis has been given. We are still yet to deliver the final prosthesis. So this is with regard to GBR before implant placement. But what about cases like these? So this patient reported to my clinic, and again, she had a broken bridge. These 2 teeth were broken, and huge periapical radiolucency was there. So as a clinician, straight away I had to make a decision whether ample bone was present or not apically to that periapical radiolucency for implant placement. So what I did was, after the CBCT, I decided I'll be going ahead with implant placement. So I extracted the root stumps and I placed 2 implants here. Now there is an issue, dear students. The socket is like this. The implant is like this. So any distance beyond 1 millimeter, 1.5 millimeter, more than the jumping distance, we have to condense a bone graft. So bone graft has to be done. That is part and parcel of GBR. This is an example of GBR at the time of implant placement. My bone graft would be easily retained in this socket. But what about this window here? So the moment I place a bone graft, this window is still exposed. So this is where I have to use a membrane. But now 3 foreign bodies are there. Implant is there, bone graft is there, membrane is there. The overall volume of the defect has increased. So the surgical site, what is very, very important is primary closure. Without primary closure, as a periodontal surgeon, your bone graft will fail, your membrane will fail. But the patient was, again, doesn't want to go like this. She is an 82-year-old female. And the first thing she asked me was, Doc, how will I attend my kitty parties as such? So beforehand itself, I had taken an impression, and Maryland prosthesis was delivered immediately after. So please understand, any person who is saying, promoting immediate loading, etc., that too in cases like these, where regeneration has to be achieved, bone grafting has to be done, immediate loading is an absolute contraindication. You have to go in for Maryland rather than immediate loading. So 2 or 3 points with regard to bone grafts you have to keep in mind, because if you follow these principles, these are the kind of results that you achieve in just 3.5 months. 82-year-old female patient, these were the results, that at the time of second stage surgery, the moment I raised the flap, this much amount of bone formation was there over the implants. I had to pick up an erotor burr and expose the implants. So what principles other than the surgical procedure we are supposed to keep in mind? A very important principle is choice of bone graft. So with regard to bone graft, again, the important thing is, before the type of bone graft, please ensure that you have the correct size of the bone graft. Particle size varies. It can be large particle or small particle. The important thing is everything is mentioned on the packet itself. So what we have to understand is that according to volume 19, Perio 2000, and otherwise also ample studies in Perio, the particle size has to be such that after condensing the particulate bone graft, the interparticulate distance has to be in the range of 100 microns. And for this, the particle size has to be 250 to 750 microns. I won't be covering up nano bone grafts here, but what is the significance of this 100 microns? 100 microns is actually the diameter of an osteon, the basic unit of bone. So one thing which we have to understand is this bone graft which we are placing, this has to be replaced by natural bone. So please, dear students, please understand, we can get away with no bone formation in an intrabony defect. The reason for that is clinically successful outcomes, that is pocket depth reduction, etc. We will be achieving even if the graft is acting just like a filler material and no bone formation is occurring in the long term. But in the case of implants, you want that bone graft to be replaced by natural bone. So please understand this thing, that ultimately what is very, very important is the choice of bone graft. If it is too large, it won't be getting resolved. It is too small, it will be getting resolved at a very fast rate. So which bone graft to use? Autografts, gold standard. But there is an issue. So this is the technique which I normally use when I have to procure an autograft. So this was a demo which I was giving for Dr. Chavi's dissertation under me in 2016, MDS 2016. So this is the area which is preferred, mandibular symphysis area. We can go as deep as possible. So the incision is given couple of millimeters beyond the mucogingival junction, and here the flap has been reflected. So we have already determined the length of the roots using CBCT. Now, this is the first instrument that you need to buy, a trephine. So trephine is roughly 5,000 rupees. This is a 5 millimeter trephine, which I have attached to the physio dispenser handpiece, and it has to be rotated at a very slow pace. So once it is rotated and you go inside, you feel a sink is there, a dip is there. Once you have gone through the cortical plate. So once we have gone through the cortical plate, the next step is Lucas bone scoop. Again, a beautiful instrument from Euphridy can be used to remove this cylinder. And this area which is raw has to be approximated back. Nothing, no need to put anything there. A nice healing would be there. Here, basically, I have used PTFE sutures. So PTFE sutures, you can use any choice of suture we can use. That is not an issue. Now, once this is the ring of bone which has been removed. So once we have removed the ring of bone, this is the second instrument with regard to autogenous bone grafting around implants or normal perio defects also that we need to buy. This is known as bone mill or bone crusher. Again, a 5,000 rupees instrument. We are crushing it. Once it is crushed, now it is ready to be put around the implant. Okay? Otherwise, the most popular choice, FDBA and DFDBA from Tata Memorial, allografts, anytime preferable. Because autografts, the issue is second surgical site, and many a times the quantity is not sufficient. So this would be my personal favorite, always and always going for allografts if possible. The xenografts which are there, bios anorganic bovine bone, that is we take bone and we heat it up. So the organic skeleton evaporates and the inorganic hydroxyapatite skeleton remains. Bios is expensive and it is a very slow resorbing bone graft. So many a times the time required for regeneration with bios is quite a bit. So that is one disadvantage, but otherwise it is a safe bet. The most, sensitive category or the category which is most dangerous is alloplast, synthetic bone graft materials, especially bioceramics. So you get few alloplasts, bioceramics, that is composition of calcium and phosphate almost equivalent to that of natural bone. The problem with bioceramics is their resorption rate is determined by the sintering temperature. So in case you go in for a not so standard bone graft, bioceramic, it won't be getting resorbed only. So later on, you are trying to raise a flap and the particles 6-8 months later on, the bone graft particles will be coming out like that only. So I would advise never ever, if possible, bioceramics, especially the few of them around implants. And choice of membrane, please understand that the membrane basically, Dr. Soumya, can you please mute it as such, Dr. Soumya? I think Soumya Sundar. So the choice of membrane, Dr. Soumya Sundar. Yeah, thank you. So basically what I said was that ultimately the choice of membrane, you don't have to go in for a very expensive membrane because rigidity is not an issue. Ultimately, the membrane will be supported by the bone graft underneath this thing. So even a normal 1200 or 1500, any collagen membrane would be sufficient. So these were few things about GBR. The next thing is gingival biotype and soft tissue augmentation. As a peri-implant surgeon, periodontal surgeon, and now peri-implant surgeon, what do we need to keep in mind? So periodontal biotype, again, the term was given by Siebert and Linde, two periodontists in 1989. Basically, it refers to the buccolingual thickness of the soft tissue. So we have issues or patients in which it is thin scalloped and where it is thick flat. So how to identify? Instead of going in for the edentulous area, we see the overall pattern of gingiva in the patient in which we have to place implants. So if it is scalloped, the scalloping, the semicircular arches are towards the more side, and we are inserting an instrument, we can see a shadow of that instrument. That is the thin type. You need to be very, very careful in such patients. Please understand that implant is surgery first, prosthetics later. If you respect the soft tissues will be respecting your bone, and the bone will be respecting your implant. Otherwise, it is bound to result in an aesthetic failure. On the other hand, if it is thick scallop means the scalloping would be lesser. These are the kind of cases in which you have nothing to worry about. You can, meaning you can have a little bit slippage of instrument, etc. also, and you will be pardoned by the tissue. These things you have to be careful. So few authors, Claffey and Shanley, have told that anything less than 1.5 is thin and more than 2 is thick. So the disadvantage is that the amount of recession is 3 times more in the case of thin biotype than thick biotype. So what happens is, not only thin biotype is less resistant to surgical trauma, not only is it less resistant to, it is also less resistant to restorative trauma. You can also injure it during taking of impressions, etc. So what are we supposed to do? So please understand, always and always, especially maxillary implants, if you are placing in a thin biotype patient, place them more palatally. Otherwise, a slight shadow would be there, titanium shadow would be there. Okay, and place them more apically, go deeper. Then only a proper emergence profile would be coming. So please understand, as a periodontal surgeon, we are the best people suited for the surgical part of implantology. Nobody can match us. But few tips and tricks we need to keep in mind. And the best tip is identify the soft tissue. Otherwise, we'll end up with problems. So how to identify this soft tissue? A current dissertation going on in our department of Dr. Salil Joshi. Soft tissue biotype we can simply identify by using a normal UNC 15 probe and applying a normal file, endodontic file stopper to it, and then measuring it with a vernier caliper. Digital vernier caliper, we can measure it on all aspects, buccal, lingual, and also on the crest. So what happens is, this is an example of a case in which it is less than 1.5, that is thin biotype. So now in this dissertation, we are actually comparing crestal bone loss after 1 year in thin biotype versus thick biotype. So now we have given our subcrestal incision. I always prefer subcrestal incision. Lance drill in the surgical stent. We are using iFix implant here. The drill stopper has gone till the depth. Now osteotomy has been prepared, and then finally implant has been placed and sutures given. Now we'll be evaluating the bone loss after 1 year. That is loading after 3 months and then 9 months after that. So the healing part, thick tissue biotype, how will you identify? So this is how we identify thick biotype, in which it is beyond 2 millimeter. So anything more than 2 millimeter, we'll be calling it as thick biotype. So these are the type of patients in which the chances of recession, soft tissue shrinkage, and ultimately bone loss are lesser. So these are the types which we can, the same steps have been followed, and we'll be comparing the this thing. Dr. Sumanti, can you please mute your mic if possible? Thank you. Thank you. So if you are not identifying the soft tissue biotype, these are the kind of situations you end up with. So a case referred from the Department of Prosto at the time of second stage surgery. This much was the amount of necrosis. Dr. Sumanti, if possible. Thank you. Dr. Sumanti H. Rao, muting of the mic. Okay. Thank you. Thank you. So this was the amount of necrosis which was present. The moment we removed the gingival former, hardly any soft tissue was present. So suppose we go in with crown placement in such a patient, what will happen is aesthetic failure will be there initially, and later on bone loss will be there, and complete failure will be there. So what are we supposed to do? As a periodontal surgeon, a procedure in which we are an expert in, that is connective tissue grafting. So here I'm creating a pouch, subepithelial pouch. Then we are supposed to take it from the palatal area. All of us are aware. The premolar area we are supposed to take. I generally prefer the trapdoor approach. So in the trapdoor approach, the epithelium, it has been reflected. Now we are removing the connective tissue. Connective tissue has been removed. This with the removed connective tissue, and sutures have been given. Now the important thing here is always procure a bigger connective tissue. The amount of connective tissue which will be required would be smaller than that, but a bigger part can be trimmed, as trimmed part cannot be made bigger. So here we have trimmed the soft tissue. And now what is happening is, with one suture, I have tagged it inside on one side. I've stabilized it on one side. And with the second suture on the other side, this is how it is stabilized on the other side. You take the epithelium, you go around, engage the connective tissue, then you bring it back. So sort of a sling suture given to stabilize the membrane. But again, it has to be subepithelial, so as to get ideal healing. So now I have achieved, put the gingival former back and given the cross-link suture explained in Linde. So with this cross-link suture, we have managed to cover up the soft tissue, the connective tissue completely. And this was the healing at 1 month. And finally, the patient had come back with the loosening of the crown after 6 months. And that time we had removed the entire crown, and this was the healing after 6 months. So ample soft tissue thickness was maintained. So this is basically soft tissue grafting, connective tissue grafting around an implant. So this is the next level of perio surgeries that we have to incorporate. All of you as students have to do in patients. Otherwise, what will happen is non-surgical specialists will keep on saying implants is our domain and all. No, connective tissue grafting is entirely a periodontal surgeon's domain. So I'll just rush it up, ma'am. Now, implant placement guidelines based on biologic width. So this is the next periodontal surgical consideration, which as a periodontal and peri-implant surgeon, all of us are supposed to keep in mind. Biologic width, all of us are aware that basically 2 millimeter distance is supposed to be there between the crown and the crest. And in case we remove this 2 millimeter, a patient has come for crown lengthening, we simply cut off this thing and we place a crown too close to the alveolar crest. It will result in bone loss or persistent inflammation. Now, this biologic width is even more important in the case of an implant because of two reasons. The first is the dimension of biologic width required around an implant is actually more, 3.08 as compared to just 2.04 around a natural tooth. Secondly, implant doesn't have PDL. So PDL, a very, very important tissue on which not just our branch relies upon, an entire specialty of orthodontics exists only because of our periodontal ligament. So PDL is not there. We cannot afford to violate biologic width around an implant. So it is based on this biologic width that we have these dimensions present. Around an implant, 3 millimeter biologic width is a must. That is 1.5 millimeter this side, 1.5 millimeter this side. So this is the principle of biologic width, which tells us that please place an implant 3 millimeters apart. Why 3 millimeter? 1.5 millimeter of this tooth and 1.5 millimeter around this implant, sorry, not tooth, and 1.5 millimeter away from the adjacent tooth. So this is the principle of biologic width, because of which this dimension, this distance between the implants have to be maintained. If this is not maintained, this crestal bone will go, and the least which we will have is interdental papillary loss. So we generally have that 1, 2, 3 rule. So I always say 1 millimeter minimum bone has to be present on the buccal and the lingual side if you're placing an implant. 2 millimeter basically means that we round off that 1.5 to 2. 2 millimeter distance should be present between the implant and the adjacent tooth. And the 3 rule basically is the interocclusal distance, that at least 3 millimeter distance has to be there. Otherwise, we won't be able to place a tooth later on. So always implant is retrospective prosthetic planning. But the prosthetic planning, more or less with regard to a single tooth implant, ends just to see whether a tooth can be placed or not. After that, biologic width has to be taken into consideration. So there are two ways in which we can ensure that the requirement of biologic width is taken care of in case that distance is not there. First is we can use a scalloped implant. Now these are not easily available. I've never used it in my lifetime. It has been only 20 years in which I have been placing implant. The first implant which I had placed was in the year 2002, but I have never used an scalloped implant. The second is going for platform switching. So platform switching basically is a concept in which the abutment is of a narrower diameter than the diameter of the implant. So this was another dissertation under me, Dr. Shiva's dissertation, and the year 2014 batch. So what Shiva did was she used platform switching, that is narrower diameter abutment as compared to the diameter of the implant. So the advantage of this is that had the abutment been of the same diameter, some amount of micro gap always exists between implant and abutment, and that micro gap generally is filled with microorganisms. So the issue is that had that micro gap been existing here, the microorganisms would have been directly in contact with bone as such. Now that micro gap is here, so all the microorganisms are actually present only on the implant surface, the shoulder of the implant, and they are not in contact with bone as such. So less bone loss because microorganisms are not in contact. Secondly, the overall, the shift is towards the medial side. So the advantage of this is that the stress shifts towards the more medial side, and ultimately the requirement of biologic width reduces. So platform switching is a thing which, if possible, we should use if the company is permitting. So this was Shiva's dissertation. We got less bone loss in the platform switched implants as such, and we can easily see this is basically platform matched abutment, meaning the abutment is of the same diameter as the implant. This is platform switched abutment. The abutment is smaller than the diameter of the implant. So this is one thing which we have to keep in mind. Coming to the last topic, that is biomodification of implant surfaces. How can we enhance or reduce bone loss around an implant? So one thing which we have to understand is that bone loss, these are again two very pioneer studies, Adel et al. 81 and Albrechtsen et al. 86, which we have to quote, which we can quote in our answers. This both emphasize the same thing. Maximum bone loss within first year of loading is there, and then subsequently it is lesser. Now the issue is, if we can reduce this bone loss also to a large extent, that will be beneficial because hardly any soft tissue recession would be there then. So ultimately what will happen is our prosthesis part, the crowns that we deliver, the patient will be more happy with this thing. So this is a major research topic of implant dissertations in perio, implant biomodification, how we can make simply that rough surface of the implant into a surface which actually favors bone formation or which prevents bone resorption. So the first dissertation that we started was again in the year 2014 batch, Dr. Sachin's dissertation. Now in Sachin's dissertation, we had gone in for PRF coated implants. So PRF, Sachin had bought, Dr. Sachin had bought our PM, again, a very impressive PG student, had bought this PRF Chokran box, and he had crushed to make this membrane, crushed the blood clot to make this membrane. Now, once this membrane was made, we had coated the implant with the membrane to place inside the osteotomy. But we faced a technical issue. The osteotomy was supposed to be narrower, is always supposed to be narrower than the diameter of the implant. So ultimately what happened was that basically that entire PRF was getting squeezed out. So next year in Dr. Divya's dissertation, 2015 batch MDS of Perio Subharti, we modified it. Instead of using the membrane, we used something known as PRF releasate. We compressed the membrane and the fluid, the liquid which came out, we coated the implant with this PRF releasate. Now this PRF releasate is actually different from IPRF. IPRF basically, again, we have used in Dr. Vidisha's dissertation. So IPRF 2018 batch is basically that you rotate it at a lower centrifugation speed, and instead of getting the membrane, we simply get the liquid PRF. This PRF also can be used, but there's an issue. PRF releasate has an advantage. The advantage of using PRF releasate, that is ultimately using this instead of this thing, membrane, is that in releasate we have this membrane also present. So what can be done is that after coating the implant with the releasate, the implant can be actually covered with the PRF membrane. In this case, I'm covering it up with the membrane. And once this PRF membrane is placed, the sutures can be given. So PRF membrane will be enhancing the soft tissue healing also. So this is a dual advantage which PRF releasate has. You modify the implant surface and you coat up that implant with a membrane, that is the PRF membrane also. So again, this is the thing which can be used. Suppose we are not interested in this thing, what do you say, platelet concentrate. So again, a word, bisphosphonate. So I was afraid to bring up this slide because I think in Ajit's lecture, the moment this slide was there, that is when that hiccup had occurred, and the entire presentation had stopped. So I'm not sure whether it has stopped right now or am I still audible? I don't know. I thought maybe bisphosphonate was jinxed or something. So, ma'am, is it still there? Am I audible?
Yeah,
Is
you're
my
audible.
okay, ma'am? So I just wanted to confirm because that is when we were asking Ajit whether this
Correct,
thing
correct.
is. So, Dr. Ajit very nicely covered up about bisphosphonates. Bisphosphonate is a very powerful drug. This is a very powerful drug, which actually stops bone resorption. So alendronate, a second generation bisphosphonate, is very commonly used, and lot of bone diseases, osteoporosis, Paget's disease, etc. And ultimately, ample number of studies in perio have shown that a single application, it is a sustained release drug. It has a very long action, very long half-life. If we were to raise a flap, normal periodontal flap, what happens is crestal bone resorption always happens a little bit. We call it RAP, regional acceleratory phenomena. These studies, these authors had already proven that after raising a flap and after debridement, before suturing it back, if we were to have a cotton pellet dipped in bisphosphonate and we were to apply it on alveolar crest, that is where crestal bone resorption would be lesser after flap surgery. So based on these studies, in an earlier dissertation under us, Dr. Ambika Chawla's dissertation, 2007, we actually modified the bone graft, a normal hydroxyapatite bone graft with alendronate, and we used it. And the results which we found were that in the bisphosphonate enhanced bone graft, the results were better than non-bisphosphonate enhanced bone graft. So based on these results, ultimately in the year 2015, another one of our PG's dissertation, what we did was we biomodified the implant surface with bisphosphonate. So please understand what we are doing here is ultimately modifying implant surface in a healthy patient. Half of the time people will say, oh, bisphosphonate implants are contraindicated. That is because that patient is taking bisphosphonate because of the underlying bony disorder. Implants are contraindicated because of the underlying bony disorder, not because of bisphosphonate. Straight away, they'll be saying cases of bronze would be there, bisphosphonate related osteonecrosis of the jaw. No, here it is different. The same drug can be used in a very, very powerful manner. We used alendronate around implants, and this was basically the thing which was used. Ultimately, what we did was that 20 milligram bisphosphonate was coated in 1 ml, was dissolved in 1 ml of normal saline, and we coated our implants with this. And finally, we irrigated the osteotomy site also with bisphosphonate. Once this was done, ultimately at the end of 1 year, we realized that the bone loss was much lesser in bisphosphonate coated implants as compared to non-bisphosphonate coated implants. We went a step ahead, and now what we did was we shifted over from bisphosphonate to simvastatin. So simvastatin also is a very powerful drug. This drug has been used basically as an anti-lipidic drug, cholesterol lowering drug. Majority of us have been taking it. Now, this property of drug has not been explored much, bone growth promotion. So what we did was we realized that based on studies, it has a dual action. It promotes bone formation, that is BMP2 production, and it has an inhibitory effect on HMG CoA reductase. So ultimately, what happens is that it reduces bone resorption and promotes bone formation. So based on these studies, ultimately what we did was normal subcrustal incision. Again, I'll just walk through this thing. Osteotomy preparation before placement of the implant, we actually dissolved the bisphosphonate in sterile water, and what we did was that we dipped the implant in simvastatin. In this simvastatin coated, and again the same thing was followed. We irrigated the osteotomy with simvastatin, and the implant was placed. Again, PGA PLA sutures, then undyed, and this was a not just a quantitative study, a qualitative study also. And what we realized was that the application at the time of osteotomy preparation and at the time of implant placement plays a major role. Not only was there less bone resorption, ultimately what happened was that the bone density around the implant in the simvastatin coated group was actually much more than the non-simvastatin coated group. So this was another study which we found. And finally, last dissertation I'll present, ma'am, hyaluronic acid. So this is again one thing which all of us can emphasize, that in case nothing else is there, we can always go in for hyaluronic acid. So hyaluronic acid, please understand, is a part of extracellular matrix. So extracellular matrix, I won't be going into the detail. We know it is collagenous and non-collagenous tissues. In non-collagenous tissues, we have proteoglycans and glycoproteins. Proteoglycans and glycoproteins both are macromolecules of carbohydrate and protein. So what is the difference? The word which comes towards the end. Proteoglycans, the major molecule is carbohydrate. Glycoproteins, the major component is protein. So in proteoglycans also, the thing which holds our body together, one particular proteoglycan, hyaluronic acid, is supposed to be very powerful. This is the one which actually holds many molecules of proteoglycans together. So proteoglycans normally have a central protein core, decorin or biglycan, with glycosaminoglycan side chains. But hyaluronic acid is so strong that it is actually binding together many molecules of proteoglycan. So if we were to use this particular hyaluronic acid for implant modification, again, this is a study which is still going on. As of now, initial good results we are getting. We are coating the implants with basically hyaluronic acid, and after coating, we are irrigating the site also. And as of now, just half the study is over, we are getting good results. So trust me when I said, I mean, at no better time could I have emphasized the importance of biomodification more than after such an impressive lecture by Dr. Ajit, who basically emphasized the importance of pharmacoceutics. He basically said this thing, that pharmacological agents are the future. We have to know what we are prescribing, and we have to believe in the power of these drugs. So as a periodontal surgeon, the same power we have to believe, not just with regard to the systemic application, the local application. So these are very powerful drugs which none of the other specialists are able to understand. So with this, ma'am, I come to the conclusion: implant maintenance. So just 2 points more. I hope I have been able to rush it up properly, ma'am. So implant maintenance, what points are we supposed to keep in mind? So the first thing which always and always I tell to all my patients when I am delivering an implant prosthesis, my implant has survived, is that I have replaced a multi-rooted tooth with a single-rooted tooth. So interproximal scalloping generally is gone. So always and always use a proxa brush, has to be advised in implant prosthesis if we want our implants to survive in the long term. The second thing is, I always show this to the patient, that this is the difference between tooth and bone. So in the case of tooth and bone, there's a very small and very powerful tissue known as periodontal ligament. The periodontal ligament has something known as proprioceptors, pressure sensitive receptors, that if we apply force, the proprioceptors tell us that force is more, kindly relieve it a little, and the tooth is safe. Here the issue is bone is directly connected, osseointegrated with implant with no periodontal ligament in between. So what that means is, since no proprioception is there to a large extent, the instruction which has to be given from implant maintenance is that we can use our implants, but never ever test our implant. We should not be applying, the patient should not be applying deliberate force, because in that case, what will happen is ultimately the implant will get compressed less, the bone will get compressed more, and this osseointegration will break. So the importance of PDL has to be emphasized. Again, examination, clinical examination is a must at regular intervals, plaque assessment, evaluation of peri-implant tissues for color, contour, consistency, etc., bleeding on probing, and ultimately peri-implant probing depths. So one thing which we have to remember as a student is that whenever we have delivered an implant, the chances of failure are more because PDL is not there. And because PDL is not there and attachment is not there directly into the cementum of PDL fibers, the peri-implant probing depths are actually more. So here, in the case of natural tooth, we say that anything above 3 millimeter is considered to be a pocket. Here, up to 5 millimeter is acceptable. So that is not an issue. Always and always, please invest in this instrument. The handle is detachable, has detachable tips. Always and always, plastic probing tips have to be used because stainless steel is actually more powerful, more strength-wise. Modulus of elasticity is more than titanium. So what will happen is otherwise you'll end up gouging your implants as such. And finally, with regard to the complications, please try to identify. There's a separate lecture on its own. Peri-implantitis. Okay, so peri-implantitis, the condition of failure, you have to realize ailing, failing, and failed implants. Ailing implants basically means you're getting some bone loss in the radiograph, but clinically no inflammation is there. So one thing which we have to realize is that ultimately, just like gingivitis precedes periodontitis, same way we have to remember that perimucositis has to precede peri-implantitis. So if bone loss is occurring without any soft tissue inflammation, most probably the issue is prosthodontic. So mainly, maybe a bigger crown has been given, a cantilever extension is there. You cannot help directly with surgical intervention. Failing implants, gingival soft tissue inflammation is there and you are getting bone loss. This is the category in which you have to intervene as a periodontal, a peri-implant surgeon. Failed implants. Mobility is not a late sign, it is the last sign with regard to peri-implantitis. If it is shaking, time to take it out. You cannot make it firm with any procedure. In failing implants, this is where you have to intervene as a peri-implant surgeon. In this also, just two tips I'll do because it is already 8:26. So the two tips is, first and foremost, always buy this instrument. It has to be plastic instrument only. It never has to be a stainless steel curette. So this is a beautiful instrument, same handpiece. This is the same handpiece of mine in which the probe tips were attached. Now I have attached the plastic curettes. Now they say it is single use, but from my experience, I have found that they're easily sterilizable. So we can sterilize them ample number of times. Only issue which I have found is they are flexible. So what happens is you have to be very patient in the debridement process. It doesn't come out easily. Now, the second thing which you have to remember is that once you have raised the flap and you have removed the granulation tissue around the implant to prevent further bone loss around the implant, and maybe you are planning to put a bone graft, the issue is how do we determine the end point of debridement? In the case of normal flap surgery, we say we have done root planing. Now here we cannot plane because it is a screw like this. So some amount of granulation tissue would be remaining in those screws, in the threads of the screw, that is the implant. So that is where, please remember that always and always chemical disinfection is part and parcel of treatment of peri-implantitis. So always use tetracycline hydrochloride, anything which can use. This is my personal choice as such. So again, the slide which brings a relief to majority of the delegates. I hope the students are still there, ma'am. I didn't bore them much. So in conclusion, I would like to say that 4 steps are there. First stage surgery, second stage surgery, impression taking, and finally crown delivery. So the last 2 steps are restorative steps. So restorative dentists, prosthodontists and all, they are like movie stars. So movie stars, what happens is they tend to come late on the movie set, and ultimately the director is shouting, telling them the script and all, but they keep on forgetting. They get ample retakes in their life. What I mean is, the restorative part, the prosthetic part, even if the impression has not come out proper, we get ample retakes. We can easily retake the impression. If the crown is not fitting, I can get a second crown fabricated. The problem with us, surgical dentists, periodontal surgeons, in which the first two steps come, we surgical dentists are actually like stage artists. So in Maharashtra, I still remember, ma'am, lot of stage shows I had attended. So stage artists basically mean that whatever we do, that is the final this thing. We don't get any retakes in life. So this is the part which has to be, we have to be proficient in. If an osteotomy is made wrong, I cannot do anything. I cannot grow bone here. If an incision has gone wrong, I'll have to manage this thing. So we are the base of implantology, not the movie stars. We are the actual stage artists of implantology. And ultimately, this is what Dental Council of India also realized, that it cannot be under a non-surgical branch like prostho. So they said OS, prostho and perio should be there. But ultimately, it is a dentist world. It became a tug of war like this. Prosthodontist, all of a sudden, overnight, they became great surgeons. Implants comes under my domain. Oral surgeons saying that I'm a big surgeon, I can place implants anywhere. Implant comes under my domain. Somewhere a poor periodontist saying that I also know how to do surgeries and I can deal with basic prosthetics. So implant comes under my domain. So while three people were actually fighting, and a few people still saying that no, we are supposed to save the tooth at all costs, implant should not be done, I always refer such critics to this particular article of Cloakworld and Newman, the authors of our Bible, that is Carenza. So three sentences from this article I always quote. First and foremost is, it says that the current success of dental implants had dramatically changed the practice of periodontics more than any other specialty. I'm not saying Newman and Cloakwood are saying. And what they said was basically that rules of periodontal therapy have been forever changed. There's been a paradigm shift from the practice of saving teeth at all costs. Rather, now what we consider is extraction of the so-called maintainable teeth to improve the aesthetics, function, and long-term success of dental implants. So this is not something which I am saying. This is an answer to the critics who still are clinging on to the past. And because of that, our specialty is suffering. Always and always I say, implants are the future. Implants we have to incorporate. So, and that is where the way a perio person can place an implant, nobody else can. It is as simple as that. So again, the eye doesn't see what the mind doesn't know. This is just the tip of the iceberg. So in the meanwhile, when Dr. Ajit's lecture was going on, I realized we are overshooting the time. So I eliminated around 50 slides or so during that course. So I've just covered up the superficial part. The advanced part I haven't covered up. Advanced part means sinus lift, direct, indirect sinus lift part, periodontal part, piezosurgical part. So any one of the delegates who is interested in learning about the various implant kits, about the various piezosurgery, they can follow our channel. It goes by my name on YouTube. You can subscribe, and there ample demonstrations we have given of direct and indirect sinus lift kit, procedure, various kits, hands-on, etc. So this is it. And thanks a lot. Any doubts any of the students have, this is my email and my WhatsApp number. And again, thanks a lot, ma'am, for considering me worthy of this honor. And ma'am, like it is an honor actually. It is an honor, like as you said, the moment such words of praise comes from a teacher, these blessings are what keeps us going, ma'am. Like we are people, we are Altivar sir's family. We basically were taught by sir that no matter what happens, this is your specialty, you have to carry it forward. So ma'am, this is just a small effort which we are doing, but always and always it is an honor and an encouragement when juniors like us get such words of appreciation from teachers like you, ma'am. So thanks a lot, not just for the invitation, but for those kind words which you said in the beginning, ma'am. And again, thanks a lot, Paul sir. Thanks a lot, Rajesh Gaikwad sir, for considering me worthy of this honor. Thank you, ma'am.
Excellent presentation, Dr. Mayur. No words to describe it. I mean, you kept on saying that I'm falling short of time, but we never thought that we have crossed 8 o'clock, 8:30. So we really missed, we will really miss you talking. I was considering that let him talk. I got so engrossed in your presentation, and it was really wonderful. Lot of applause you have got in the chat box. And I would like to address few questions by our postgraduates who are very attentive for your presentation also. One comes
Yes.
from Dr. Ishtia, who asks you that what should be the size of ostectomy in case of biomodification of implant with bisphosphonates? And what about the sterilization protocol for implant surface biomodification with PRF?
Yes, ma'am. Ma'am, the first part of the question with regard to the size of the osteotomy. So size of the osteotomy with regard to an active implant, the same size has to be followed. So we generally follow 0.5 mm lesser in the mandible than the diameter of the implant and 1 mm lesser in the maxilla. The size of the osteotomy is not altered in the case of biomodification. We have to use the same size osteotomy. That is why I don't promote use of PRF, the normal PRF, LPRF, because in that case, it is impossible to place it with the same sized osteotomy. So ultimately, it has to be a liquid, either IPRF or PRF releasate as such, and the size of the osteotomy has to remain the same. It has to be smaller than the size of the distinct implant. First thing. The second part, sterilization protocol. Now, this is again one thing which I always emphasize, that we cannot directly depend on an oral pathologist, no offense, because they are used to taking out blood and then testing it in the lab. Here, we have to prepare a blood product and we have to put it back in the patient's mouth. So again, my personal bet is TPRF or even IPRF in titanium tubes. The reason for that is titanium can be autoclaved again and again. Otherwise, we have to use disposable glass tubes and we have to sterilize them in hot air oven. So ultimately, with regard to the sterilization protocol, like instead of getting some advantage, you'll be getting a disadvantage if sterilization protocol is breached in the preparation of the PRF. So all test tubes, all lancets, everything has to be properly sterile. The sterilization protocol has to be actually more immaculate if we are using a platelet concentrate in implantology rather than our normal distance. So I would recommend either hot air oven for the glass tubes or titanium tubes. The titanium tube number, the dealer from which we get our titanium tubes also, I can put it on the group later on, and we can use titanium tubes as such.
I think the DCI has to recommend now as a important equipment hot air oven in the departments also now.
Exactly, ma'am.
Recommendations.
Yes, ma'am. Yes, ma'am.
So I hope Dr. Ishtiaq is satisfied with his answer. Next is Dr. Himani. She has to say how to make tetracycline solution or gel for peri-implantitis treatment. Very true.
Ma'am, basically what happens is 50 milligram per ml is sufficient. So it generally dissolves in saline also and distilled water also. So we get a tablet, a capsule of doxycycline hydrochloride. Hyclate is not easily available. So the normal doxycycline hydrochloride, if we were to dissolve 50 milligram in 1 ml of distilled water, we get a solution. And now we can irrigate. The important thing that we have to remember is it is acid base. So once we have irrigated it and left it for some time, we can wash it away also simultaneously with saline rather than leaving hydrochloride inside. So 50 milligram doxycycline hydrochloride capsule dissolved in 1 ml of distilled water. That is how we prepare, ma'am.
Next is Dr. Kamal. I think this is the last question. The person has to say that during immediate implant placement, most of the cases she has not been unable to close the flap by primary intention or close the flap properly. How do I avoid such problems?
Ma'am, in the case of maxillary anterior or mandibular anterior, this issue is not there. The reason for that is we can always give vertical incision and we close it easily. This issue we generally face in the case of posterior multi-rooted tooth we have extracted, and closure is a big issue. The issue is actually made more worse because we cannot give a vertical incision in the area of mental nerve. So my recommendation is two things, ma'am. Firstly, we have to try to approximate it first. In case we are anticipating that this approximation won't be possible, then we should go in for type 2 implant placement rather than type 1. So type 1 is immediate implant placement. Type 2 is implant placement after 30 days of extraction. That is, we have extracted the tooth and we simply let it heal from an epithelial point of view for roughly 30 days or so. So in 30 days, basically what happens is soft tissue healing is complete, and now we treat the socket like a fresh socket, immediate extraction wound. So that is type 2 after 30 days. Otherwise, we can go in for socket preservation also in case we feel bone grafting should be done and implant should be placed at a later on date, but that will delay it further. So instead of type 1 immediate, if we go in for type 2, we just wait 3 to 4 weeks and then place the implant like type 1. That is the best thing. Type 3 basically is that patient got the tooth extracted roughly 3 months back, and in the radiograph, we are still able to see the outline of the roots. So basically bone has formed, but it is basically woven bone. So the osteotomy has to be much more narrower than the diameter of the implant. And type 4 is delayed. More than 6 months have elapsed. So we go in with the normal osteotomy. So type 2 is more like type 1 in implant placement and osteotomy. And type 3 is more like type 4. So my suggestion is always very simple, that especially in molars, if we are not sure that we'll be able to approximate, never ever leave the implant exposed, because ultimately, ma'am, in a multi-rooted tooth, the socket would be that huge. Our implant would be like this. It has to be filled with particulate bone graft. Membrane cannot substitute for primary wound closure. Rather, one of the primary characteristics of membrane is full closure has to be there. No membrane exposure has to be there. So in case we are anticipating that primary closure won't be possible, we should delay the implant placement by just a couple of weeks after extraction, and then we'll be able to close it easily. That is my take. Type 2. Type 2, ma'am, is very less frequently practiced many a times. That should not be there. Okay?
This is an excellent tip, Dr. Mayur. The last question is, what should be the nature of bone graft for jumping distance?
Nature of bone graft, ma'am, basically, my personal take on jumping distances, I'm a very, or to say conservative person. I say anything beyond 1 mm, you have to place a bone graft somehow. So my take is anything 250 to 500 microns, preferably less than 500 microns, bone graft should be placed. And my personal favorite always and always is allograft. FDB or DFDB, both are good of Tata Memorial. I would openly recommend them, but always allograft rather than xenograft, never alloplast. I wouldn't recommend. The problem with autograft also, ma'am, with regard to immediate implant cases is, even when we are crushing it in bone mill, the bone crusher, the particles that we get are not uniform at all. So many a times condensing them to the base of the defect is not that easy. So it looks good on paper that they are osteogenic, but from a technical point of view, they are very difficult to condense. So my take would be anything less than 500 microns and allograft. That would be my this thing. And with regard to jumping distance, anything more than 1 mm, condense a bone graft. We should condense a bone graft, ma'am.
So thank you very much, Dr. Mayur. And we end the session here. And I feel that it is one of the biggest success for Mumbai Study Group. Hats off to our pioneer periodontist and our teacher, Dr. Paul sir, for literally initiating us and motivating us, inspiring us throughout the year that yes, we have to kaitari karaitsa hai, we have to come forward. And of course, he has hand in hand Dr. Rajesh Gaikwad, who is always there for us. So I thank my entire team for giving me the opportunity to be the organizing chairperson today. And I'm honored to introduce this excellent speakers for today, Dr. Ajit Nair and Dr. Manish Kaushik. I have no words to praise you both, and I'm really thankful that I have been here amongst you. And I hand it over to the Master of Ceremony now. Thanks a lot. Rajesh?
So, hello.
Yeah,
Yes.
you're audible.
Yes. Basically, as our secretary sir said, ISP secretary sir said that this usually we end this ISP PG convention with we have started with Oral Hygiene Day on 1st of August. This year we have celebrated in a grand way in collaboration with Indian Society of Periodontology Mumbai Study Group, IDA Mumbai branch, and Government Dental College and Hospital Mumbai. I basically thank Dean Dr. Dimple Padave for making necessary things and permissions available. We have celebrated this Oral Hygiene Day this year by celebrating rallies, by way of conducting rallies, exhibition, poster exhibition, flash mobs at Nariman Point, at CST, and majorly we have conducted various dental camps and awareness lectures to the police training centers where we have covered more than 1,000 police personnel. So coming to the today's ISP MHG convention, I basically thank to both the dynamic speakers, Dr. Ajit Nair and Dr. Mayur Kaushik, for delivering their excellent lecture on their topics, and they have given full justice to the topic. Then Dr. Varsha Rathore Madam, organizing chairman, beautifully coordinated the total entire show beautifully. Then our dynamic secretary of ISP, Dr. H.S. Grover, and President Dr. Manish Khatri, thanks for being there for our ISP MHG convention. Then Dr. Lynette and Dr. Vaibhavi for hosting this show, and our president of ISP Mumbai Study Group, Dr. DG Pol, for always guiding and always encouraging this show. We had for this lecture we had some prominent and senior faculties were present. I will just mention few: Dr. Sangeeta Mugulikar Madam, Dr. Sureka Bedasgaonkar Madam, Dr. Pradeep Chitnis Sir, Dr. Babita Pawar. Then Dr. Selva Kumar also had joined. Then
Dr. Pramod Maravar.
Maravar sir was also there. Maravar sir was also there. Dr. Babita Pawar Madam was there. Then my department staff, Dr. Akshay, Dr. Chitra, Dr. Gulnar, Dr. Nilofar, then Dr. Vinayak Thorat from BVP, again Bennett Fernandez, and Dr. Kiran Suradkar, Dr. Om Baghele. Actually, Om Baghele again is a pioneer. He was present during first Oral Hygiene Day with Paul sir. Dr. Om Baghele. Then yes. So I have mentioned Dr. Lisa Chako from Sangamner, Dr. Poonam Rai. So all majority staff members and lots of postgraduate students were there. So I definitely feel that this session will definitely boost at least some sort of knowledge to and expertise to the postgraduate students. And I thank all my Mumbai study group members for joining this beautiful lecture, and we will be making this lecture available on various social media like Facebook and Insta. So thank you everyone. Dr. Vaibhavi.
Yes, sir. Thank you so much, sir. I would like to thank Dr. Ajit Nair, sir, and Mayur Kaushik, sir, for their remarkable lecture on these basic concepts of pedontology and implantology. It was very refreshing and knowledgeable. I'm sure that today's webinar was very helpful for all the budding pedontists like me. And I think we will end this session on a good note. On this very Janmashtami occasion, I would like to thank everybody who has joined today, all the participants, delegates, faculty members, everybody. Thank you so much, and hopefully we'll meet again for this like this webinar again.
Thank you. Thank you very much.
Thank you.
Thank you, sir. Thank you, sir.
Thank you.
Thank you very much. Thank you, sir.
Thank you, sir. Thank you, ma'am. Thank you. See you.
Thank you,
Thank you,
Mayur. Thank you,
Ah,
ma'am.
most welcome. Thank you.
Thank you, Arsha.
Thank you, sir.
Thank you. Thank you. Thank you.
Bye.
Bye.